Good morning, good afternoon, good evening to you all. Welcome to the online advanced course on Biomedical Imaging 2024. Today, we will have a panel of experts to talk about proton therapy. I would like to remind you that you can send your questions via the Q&A chat box or express your intention to ask the questions orally by activating the Raise the Hand button. All questions will be answered at the end of each talk. Now, without further ado, I give the floor to Professor Ana Margarida Abrantes from the Faculty of Medicine of the University of Coimbra.
Good afternoon. I will present the first speaker, Dr. Volk Ponisch. Dr. Volk Ponisch from the Department of Radiation Physics of the Division of Radiation Oncology is doctor in physics since 2003. After that, since 2009, Dr. Volk developed expertise in proton therapy, spending most of the time as clinical physicist, but also work on different projects related to proton therapy, including quality assurance and the impact of protons on pacemakers. With strong background in research and clinical applications of radiation therapy using photons, carbon, and protons, today he will speak about the principles and practice of proton therapy. Dr. Volk, thank you very much.
Thank you, Dr. Abrantes, for the nice introduction. I want to, this is the speaker, the general about proton therapy. So why proton therapy? General proton system overview, then the proton delivery methods and the radiation treatment workflow, including uncertainty discussion, passive scattering planning, and scanning beam planning. So why proton therapy? So already in 1946, Robert Wilson suggested to use proton therapy in cancer therapy because of the low entrance dose, and then the dose increases.
Dr. Volk, excuse me, yes? I don't know, but you didn't put the presentation. I don't know if you...
I'm not sharing it. I'm sorry.
No, it's
I'm
not
very
shared.
sorry.
No, it's okay.
How about this?
Okay, now it's shared. Okay, thank you very much.
I'm very sorry.
No, it's okay.
So you just missed the outline, and then so why proton therapy? Again, you have in low entrance dose, and then the dose increases, and in the Bragg peak, which is pronounced maximum in dose, and after that it falls up sharply, and in case of protons, it goes the dose goes down to 0 here. However, as I put an asterisk here, if you have heavy ion, you have fragmentation, and then you have a certain tail on this. So therefore, protons are suited for deep-seated tumor. You have less dose to the OIR, and you could potentially escalate dose to the target. And so all this stuff is still true. And why is not moving forward? How about this? So, however, a single Bragg peak is not good enough. We need to expand the Bragg peak, and so this is called a spread out Bragg peak, also short SOBP. This is achieved by superimposing various Bragg peaks of different energies at different intensity. And so this can be achieved by the synchrotron in a very predictable manner. And this was published by L. Smith. And so this is the outline of PTC1, which is pretty much the same for PTC2. And the only difference is the number of rooms. The overall concept is the same. You have a synchrotron here, then you have a beamline transport, and then it goes into individual rooms. So this is the picture of PTC2. This is inside the room, and so and I have a comparison at the end. You see, it's pretty much the same. The difference is the robot for inside the room. This has some benefits, and this is much more flexible. We had a 6 degree of freedom couch before, but this one here is really designed to do this. So anyway, back to the layout. So the synchrotron is here. It has 4 magnets instead of 6. These rooms are all the same, unlike the previous one where you had passive room and scanning beam room. They are all scanning beam now, and they are lined up here. And the main thing you may notice, which is not really clear in this drawing, because this is a drawing from the building people. Here, there's no maze anymore. So we have a mazeless system. So this shortened the overall footprint in this direction. And so instead, there's a 2-foot wide shielding door sitting in between here. And and it goes, has two, they're going together, and that's the layout here. So what's unique between the rooms is that these 2 rooms here in the back have CT on rails, as depicted here by this thing from Siemens. We currently commission this device, and it's functioning, and we will probably get this available for the clinic soon. We have surface imaging in 2 rooms. We can expand it to others if the money is there and the usability is there. Surface imaging means you have a 3D camera that looks at the patient and compares today's image with a reference image. And that can be very useful for certain disease sites. Then the other item here is all rooms have cone beam CT. So you can see here in this, the covered panel or the protected panel, and there's an X-ray on both sides. So you have 2 X-rays, which is kind of a unique situation compared to regular Linac. And so you could have both X-rays on at the same time and rotating the gantry, and then you can do a circular image of a patient, and then you can reconstruct a 3D CT. Then the other unique thing, which we haven't commissioned yet, but it's available, and it's software that allows you to track the motion. Hitachi calls it RT-RT, developed by the Hokkaido University. What it means is you have the X-ray as a fluoroscopic mode on, and then you're tracking the fiducial inside the patient. And then while you're tracking it, you're turning the beam on and off when the tumor is in the right position. So that's the equipment. So this is the old schematic. I need to update this, but the concept is actually very, very similar. So the number of magnets is about the same, or dipoles. There is one additional one inside the nozzle now, and this improves the stability or the position of the beam. The other thing is, in a similar fashion as in the current system, we have exactly the same Linac. It actually consists of 2 Linacs put together. However, one of them is called an RF quadrupole, and the second one is a drift tube. It's exactly the same. The only difference is the shape of the cavity has a different size, and the energy that feeds the second one is already 3.5 MeV. So this is this wing. The wing is about the same between the 2. The new one is slightly tighter, but it's more rectangular. This one is more circular here, and it has 6 magnets here. The red things are the magnets. Then here is the off kicker, meaning there's a frequency going in, and when the proton pass by this position here, they are, by the way, about between a tenth and a third of the speed of light, so they're pretty fast. here the system knows when the proton passes, and then the frequency is set, and therefore the proton will extract it from the circle. It's actually more of a shaving of the proton, so only the outer row, or the outer path are being extracted, and then this is then the beamline transport. You have a picture for the same thing, but now the beamline transport here. This is a picture from the original design. It's exactly the same, actually, with the new one. The dimensions are the same. What is so this was initially assembled in Japan and then brought over to US. So this is the massive support structure. So the SED is the same, the weight is the same, diameter the same. Rotation speed is the same, so it rotates 1 revolution per minute. 360 rotation, that's important for us, which means it allows us any gantry angle we want to use. That's not, some people do for weight serving purpose. They have a different design and it allows only 180 degree, which means the gantry rotates only from here to here. That makes the back end a little bit cheaper, and therefore people choose it. The downside of this is you would need to this is going away, so this is shorter, but you need to have a table that rotates plus minus 180 degree. So you need to have a different robotic arrangement. Position accuracy is 0.5. There is a counterweight on the back to compensate the magnet and all the devices on this. The accuracy is 1 millimeter over 360 degree rotation, so it's pretty impressive considering the large dimension of this object. So this is the treatment room, that's the original one, and this is the new one. So I had this picture before with a phantom on it. So overall, it's exactly the same. So the only, as I said, the only change is the robotic and the design of the nozzle. Yeah, so on the old machine, I mentioned this before, we shut this thing down a month ago. So I still will talk about the overall concept. So you can say from now, passive scattering is an ancient thing. People don't do anymore. But it has some benefits, and I personally like it a lot because the main difference between the two is the forward planning. So you can do forward planning here. This is more like a 3D planning, whereas this one here is inverse planning, IMPT, BMAT. So it's a totally different optimization method. Here, the user is optimizing the field, whereas here the computer is. So you need to define the objective, and I come to this later. But what is the characteristic of passive scattering? It's lateral scattering. You collimate the beam. You're spreading the range, collimating the field, as I just said, and you do distal collimation as well. So here's the overall concept. That means you have a range modulator. So you have a very fine, a very narrow pencil beam coming in. Now you need to go to the first scatterer. This is just reversed. In ours, it is we have the arm W in between the first scatter and this. So it doesn't change anything on the whole overall concept. So you widen the beam a little bit, then comes the range modulator wheel, which is a triangular shaped thing. It rotates and it has 6 modulation per rotation. Then it hits the second scatter. This is schematic. The second scatter doesn't look like this. It's just a disk with different shapes and different metals. And that spreads this beam further. And at the end here, you have already uniform uniform dose. Then of course, since you're going further away, this is very close to the entrance of the nozzle. Here, this is closer to the isocenter. You have very uniform dose over a rather large area. Now you need to collimate those. This is done by apertures, and then distal blocking you do with the compensator. And as a result of this, you can shape a target like this very well distally, but you can't shape the target proximally. So you irradiate a little bit more normal tissue here, but you can have different beam angles, which makes this very conformal. But this is the same thing for the lateral scattering. And the main thing here is double, well, this is saying already double scattering because it has a second scatterer. So you have a first scatter, then a second scatter right here, and then the collimator. So here a picture of the range modulator wheel. This one is made of aluminum or plastic. The beam penetrates to this and rotates at 400 RPM, so it's pretty fast and it's actually pretty bulky. So this thing is about 20 cm this way, so 20 cm diameter. And then it hooks up to a motor, and then it's the overall delivery is triggered by the position of the arm W. So the beam knows exactly where the arm W is, and then turns on and off the beam in nanosecond interval, so that it knows it gives even different intensity along these steps. So by turning on and off the beam, and that as a result of this, if this thing is not rotating, you have your pristine beak, and by modulating it here, you can achieve and spread out black peak. That's what's showing here. But the main thing is really that this is not this. So you use one arm W for whatever SWP you use. But this is it's kind of an interesting, very efficient design. So the first designs on this, they just had this spinning wheel, and what you could do is you had it beam on all the time, and this thing spins, and then the modulation is only the maximum so-called full modulation ability. And here, with the turning on and off the beam, you can create shorter SWP, and so by doing so, reduce the dose at the entrance. So now comes to the collimating device. We used aperture, and we still use aperture because it's easily millable. We had for passive scattering 3 sizes. We use also apertures for skinning beam. And that's one of the advantages with passive scattering, actually, that your penumbra for low energies is very, very sharp. Compensator is an acrylic. It's smooth surface, so the 3D object of the rendering of the patient distal edge, and its thickness can be anywhere between 2 and 15 cm. So what does the compensator do? It shapes the distal edge of the target. Without compensator, you would have a flat edge. With compensator, you have a shape any way you want. So now the scanning beam, this is now every unit that they sell in the US is a scanning beam, whether this is a 1-room system or a 4-room system they have here. So the main thing is you have, in a similar fashion as a passive scattering, but instead of having hardware that doesn't do anything except actually the beam turns on and off, what you do here is, aside from turning beam on and off, you're also controlling the position of the beam by having 2 magnets that scan in different directions. Of course, this is a magnetic drawing, it's not the real thing, but you can deviate the beam in this direction as well as an up and down. And then you can change the beam on time, and by doing so, you're changing the dose on in the individual way. So the distal one gets more and the proximal one a little bit less. And by doing so, you can paint the entire target. And this was an old paper from Tony Lomax in grade 10. The point was that you don't have any wasted, and this is true to some degree. With the wasted is actually an interesting thing that it depends a little bit on the design of your scattering system. So our design was very advanced, and because of this, we had very little loss. However, you have neutron production in passive scattering more than with scanning beams, so you're not wasting any of those. So you don't produce neutron or much less neutron. The neutrons produced are only inside the field, either inside or mostly inside the patient, because the proton aren't interacting with anything until they get to the patient. So here's more of a schematic sketch. This is about the same. The only difference between this picture and one for PTC2 is that this is anyway a schematic picture. So there's no dimension to this, not for scale. But you see the magnets in, and so the point is you're dividing your target into different layers, and each layers gets different spot positions, and on top of the different weights. So if the weight is 0, then you don't get a spot, so you can get holes in your distribution. But overall, if you sum all of them up, then you get a uniform. Yeah, it's a schematic. So by summing all them up, you're getting an SVP. Well, this is more for scale drawing here. This has changed a little bit. So this portion has been compressed a little bit because there's no X-ray tube anymore. So this thing gets closer to the patient. The rest is all the same. The only difference is the thickness of the energy absorber. And why is that? Because our energy, you cannot accelerate with a synchrotron very low energies. So you're limited in both systems to about 4 cm. So you cannot lower the energy any further. And in order to treat superficial tumors, you would need to put in an energy absorber. Hitachi called it energy absorber. Now it's common term to call it range shifter. So it's just a piece of plastic that you put in, and that retracts the overall range. The other parameter are about the same, except that the spot size now for PTC2 is much better. It's almost a factor of 2 smaller. This is, by the way, sigma, so not full of maximum. Oh, one thing I forgot. So this thing has helium chamber in here. So helium chamber was designed to make the system, or perceived to make the system safer. But it didn't really add any values to this because the vacuum window is here, and then it's it is a tube filled with helium. So if this tube would be filled with vacuum, there would be no penalty, and that's what's happening at PTC2. So the only concern could be, oh, if the vacuum implode, then what can happen? Yeah, then there is air in the vacuum. That's the so it's just a tube filled with vacuum in the PTC2 case. And the other thing is, as indicated here, this thing is movable, and that's very important. That's very unique for scanning beam. What this does is it moves the position of the range shifter closer to the patient, and by doing so, you're making the spot. You don't have divergence of the beam. You limit the divergence of the beam, and therefore you're collimating the proton beam much better this way. So here an example of how the spot would look like. Here, this is a QA test pattern. So you can deliver any energy, you can deliver at any position, and the only limitation from the physics point of view is the spot size. Please notice this is centimeter, so that's not good. So that's for PTC 1, and for PTC 2 we have them. So it's more like here on this end. So it's now much better, and you can see this on the plan. It's it's so easy to get good plans now. Another thing is the spots placement, and so there was a theoretical assumption what can happen, and this was recently shown by the Mayo people, where they found that Hitachi in a certain energy range at around 180 MeV had spot position delivery issues, and so these spots were moved to the left in one. I don't know. I go a little bit tic tac. They were moved in to the left or to the right, depending on which one is. And so the painting was along. I know this is not a good figure. Should I brought this up? The painting is not only in this direction, it's a 2D painting, right? And so what's happening is you moving in and out here, then you go to the next one, in and out, and at some point you run out of proton. Then you reload the synchrotron within a fraction of a second, but you're still reloading it, and then you're delivering it again, and now the spot position has shifted by a fraction of a millimeter even. Remember, the spot size is much sharper than indicated in this picture. And now this 1.5 sigma rule is not given anymore. So the sigma I had put in here, or for maximum, we can calculate the sigma from it. But now you would need to have 1.5. If you go over this, then you're seeing shapes like this. So if you have a Gaussian, you should be 1 sigma away in order to make it flat. However, if you're systematically placing the spot wrong, then you need more than this. And that was one of the findings there. And it was unusual that the spot position changes from one spill to the next, and this happens only in one particular energy range. And we could see this also hinting. So what we do because of this, we have our spot placement is much more packed onto each other. So what's happening then is even if it stops here, the next spot is very close to this, and so then it's still uniform. Well, that's the solution. So there's really no both deliveries between the spills are within tolerance, so it's all fine. But what you shouldn't do is you shouldn't pack them too far apart. So again, this is a summary of passive scattering versus scanning beam. It is still true to these days. So it's a mature technology. It's, as I say, passive. So specific hardware is required, but it's not sensitive for electronics. Larger gantry housing is required, lens sensitive to organ motion, and so organ motion mitigation is needed. Higher neutron production. So now it comes to the workflow. So start with simulation, then we do the going to the treatment planning system. The scan is imported by the dosimetrist. The physician is contouring the organ at risk and the targets. Then the actual planning starts, and we're trying to automate those things now, and we're making good progress on this. And then the physician reviews it and chart processing, and then QA by the physicist. Here, now these individual steps, details. So the first thing is immobilizing the patient. So the patient is sitting on a vac lock. with a mask. So that with the backlog, make sure that the patient doesn't move left and right, the mask that the patient doesn't go anywhere in the head region. And the mask is fixated onto the table, so there's very little motion. It's a little bit discomfortable, but it's to ensure that the patient is in the same position during treatment as it was for the planning. So other simulation devices for different disease sites. So this is for thoracic. We use a T-bar, here the shape of a T, with a headrest under it. We're not treating through this. So it's just for immobilizing the head and the arms, because you want to get the arms out because you want to treat this region. For prostate, of course, you want to treat this one. So we occasionally put a rectal balloon, but we have now the spacer, and that works much better. That separates the, unlike the rectal balloon, which can push the rectum into the or closer to the prostate, the spacer puts them apart. Leg embolization is done with this device. The bladder filling is checked. So this is for cranial spinal simulation. So again, the backlog, and what I want to point out is there's under this, because we're treating the entire spine, is very uniform. So with that, so this is what we want to see from physics point of view. It doesn't matter how thick this is, it's just that it needs to be uniform. And when it's uniform, then it's not sensitive to setup uncertainty. So we use mouthpieces for our head and neck, as well as for this CSI patients, and the whole backlog. So we're debating currently. The backlog is a difficult thing to use. So we're debating whether we should get rid of it. But because this is not needed, the shape here, but it's I think it's adds a little bit of patient comfort, but yeah, it's difficult to handle because it can leak, and if it leaks, then we are in trouble. So that's something that the manufacturer probably has to improve. So this is the old table. This is the CIFCO type of table. So this is an S shape here. They call it S. I don't see an S here, but that's the head portion, and this is the shoulder portion. The overall, it's a good design. However, it's very uniform under it, but it has some limitations here in this, as well as these edges here. Well, it has rounded edges, but we still cannot use a beam going to this. And this is something we recently started doing, and it improved a lot on the plan. It makes the planning much easier. So how does the physician contours a patient, the tumor in particular? So the MRI shows the tumor much better than a CT does. So the MRI is overlaid to the CT. And we have MRI CT simulation, which means unlike in other centers where the MRI is fused onto the CT, we have the actual setup devices in the MR, and then it's so especially in the neck region, the shape of the neck changes. You never get it in the same way if you do it in the diagnostic imaging. So with the MR sim, you can have a much better alignment. The patient's head isn't tilted, and so the registration is much better. And then the physician draws the target. This is a fake target that I put in. Then the OAR for the brainstem. And what can happen is sometimes that the target is overlapping to the brainstem, and then comes the problem with the planning. And the physician puts the planning directive in, which states the prescription, what are the targets and the margins. And then the normal tissues, what you want to achieve. So there may have been actually an actual patient. I'm sorry for that. But regardless, so we try to do multiple beam angles. We use depending on whether we need for scanning beam, we need an energy absorber or not, because this one is fairly superficial, so it may be beneficial to do this. So what about the range uncertainty? So as I mentioned before, protons stop, and so you need to make sure that the protons stop at the place where you think they do. So we can measure this precisely in water, but what about in the patient? And this is not so sure. So the main thing is the relative stopping power to HU conversion curve. And based on the Moyer paper in medical dosimetry, as well as in the task group report, the recommended range uncertainty is 3.5%, which can be reduced if you have dual energy, but that's another topic. So as a result of this 3.5% add a lot of margin distally and proximal to the target. And so it's really not ideal, or this is one of the main limiting factors right now. And because of this, the scanning beam is sometimes not as good as the VMAT plan. So one of the possible mitigation strategy is use the dual energy CT. This could reduce it to potentially 2%. One of the main thing, in my opinion, and we have shown this, is the dual energy CT is not dependent anymore on the beam hardening, and that's the main limitation. So this 3.5% aside from the tissue, even if you're in this region, the beam hardening can have a substantial effect on the HU. So this can move these points in either one of that direction. And so depending on whether you're treating the head or the pelvic, you get different HU even though you put the same plugs in. The plug is a disc with tiny tissue substitute, and you have exactly the same CT. You have, but the only thing is you have a different phantom size, and you get different Hounsfield unit. And this is totally eliminated with a dual energy CT. The other option that has been published is upon proton radiography. So you overshooting the target. That's a nice way of doing it. But I think it's a bit fancy, and once you have validated, you don't need it anymore. In vivo range verification, so this is one of the research project we have with PET or prompt gamma. And then the other more feasible mitigation techniques are robust optimization or adding margin. The other contributing factor are a high Z material. So they have option to do reconstruct artifact reconstruction algorithm that works to some degree, let's say, but not ideal. So what's happening is at the end, the dosimetrist overrides the entire portion here, and the metal is entirely avoided by the treatment plan. And that's one of the features the modern treatment planning system can do to avoid this. And if you're not treating through it, then you don't need to worry about the actual Hounsfield unit. The other thing is heterogeneous media. What can happen, so was shown by Uri. If you treat to lung tissue, then you can have this range straggling, and so Monte Carlo is supposed to account for that. So today's algorithm are all Monte Carlo, so that's and some are better than the others, but they're all Monte Carlo. However, they rely on a model, which is so they're converting the measured data into a phase space, and then using this phase space and this phase space needs to be reflecting what your machine comes out. But it's important to check during commissioning of the TPS. So what are other uncertainty? Position uncertainty for the patient, random or systematic. So on a day-to-day, the patient position can vary. We're trying to minimize it by taking the X-ray and doing cone beam CT now. So we're minimizing this, but then there's a residual error, and that's the systematic one, which is fairly small if the machine is out of specs, or meaning that the table or the imaging center is not the radiation center. And that can be so can be this one is always there. For instance, you have a certain beam angle where the beam is always off by a small amount. It's still within specs, but it's always off by this amount and always in the same direction. Then you can align the patient any way you want, but you have a certain finite limitation of how accurate you can deliver a beam. So this is the pros and cons actually for scanning versus passive as well, because this doesn't apply to passive. Moving target is another thing. For companies that we do smear 4D planning, that's now our standard for IMPT planning, which means we use the average CT and we use the T0 and T50 phase of the CT and planning to all 3 CTs together, and this accounts for motion. And this works really well for IMPT. It keeps the dose conformal and by providing robustness over the motion. If the motion, however, is too large, then gating and Bruffold technique should be utilized. And we had this in the old system, and we will have soon this again. We use a different system. It's from CVAT. The surface imaging provides Bruffold or motion tracking as well, and that's functional. But we need to commission this and making it work on the Phantom and see whether it still works the way the vendor has promised it. Then we have interfractional changes such as tumor shrinkage or weight loss. The only way is really verification plan and plan adaptation. So one thing I didn't mention yet, and this may come at a later point, and I actually don't want to talk about this too much, but I just want to mention it, and that is the LET/RBE. And why do I not mention it? Because well, let me explain what it is first. So you have a beam, it's stylized example where the OIR is here and your target is presumably here. So your target potentially overlaps and the beam ends inside your OIR. So this is then having a plot along this axis shows here. And what's happening now is depending on the dose per fraction, this is the RBE dose shown here on this side. So the RBE suddenly increases by a lot. But at the same time, the dose also reduces. So you would need to multiply this with this and you get the actual value. But you have an amplification of the dose in the distal end. And this can be up to 20 or 30% more than what the plan suggests. So that would not be so good because then you have a shape of the dose that looks like this. So that is not good. And as a result of this, how to mitigate this is 2 ways. You can either have a model, an RBE model that has this included, and you have an optimizer that does it. So commercially, it's coming out right now from research in version. Actually, yes, it just came out in version 12B. They have this as an option, and so we will upgrade it by the end of the year. We will upgrade this, and so what the optimizer will know that this is happening, and then it will not place spots inside this. It will lower the dose in this region. And this is an important effect, or it's a minor effect for Proton, but it's an important effect for Carbon and other hadrons. So you cannot get away without that. So they had to develop it for Carbon, and now using the same technique, they can also use this for Proton. So so beam angle selection, I will skip this portion here because I go straight to scanning beam. As I said, scanning beam is inverse planning. So what you do is you put this, by the way, is still eclipse, but the concept is the same. You have an upper and a lower constraints for the maximum dose and minimum dose, and then you're setting priorities, and then you deciding, oh, do I want to have robustly optimized? Yes, we want to have the target robustly optimized. Do we want to have the brainstem robustly optimized? This depends on the dose level, and so this is up to the planning directive. So what the optimizer then does is it calculates the cost function out of this. So how far are we away from your goal? So in this case, we met it already, so our cost function is pretty low. Whereas here we are a little bit off, so the cost function is higher for the target, and you can see this here. CTV and GTV has a much higher cost function, and brainstem doesn't have any cost function. Which means what we don't meet is currently, because we are in the beginning of the iteration, we don't meet the target, so we need to improve the target coverage, and this is where the optimizer works. It minimizes the cost function and improves the overall plan. So of course this requires you to put the proper objective in and the proper priorities, and that's where the art of planning comes from, what the dosimetrists are doing. So overall you have the option so-called single field optimization or multi-field optimization. Single field optimization, in my opinion, still has its value, and especially considering the RBE business. So if you have, especially for instance, for prostate planning, you have two opposing beams, and it's very beneficial to have a uniform dose there. And so you can have the uniform dose from both beams, and then the RBE is then suddenly not in effect anymore. So the single field optimization has its value, but you cannot. It's only workable for simple volumes. So if you have concave shaped objects, you can't do that. So for most plants, I would say for all other sites but prostates and maybe some breast plants, you would have multi-field optimization. So this is true IMPT, which means you're weighting all beams together in energy and position, and by combining all of them, you're getting a perfect plan. And so this is an example for an SFO plan. Here the beam comes this way, sorry, and this beam comes this way, and then they combine this. Then you have a uniform dose. You had a uniform dose to begin with, and then of course this shows only the physical or the constant RBE dose. So then you would still get a uniform dose with this arrangement. So this is if you this is misspelled, I'm sorry. It's called MFO. So if you would ask the system to do MFO on this with robust planning, you would get a shape like this. You see suddenly this dose is dropping here. This does the same here. And now by combining it, you get the same dose. But the individual beams have different doses actually. So you can say that's okay, but I think and from the RBE it's actually also not so bad because the dose is dropping. But the downside of this is you have more entrance dose. So I'm not sure whether you really want that. But you need to weigh the RBE versus the downside of the entrance dose. So so then plan review. So we're looking at the 2D slices, we look at the DVH, and then we have the dose statistic as well as the clinical goals now. Then comes the patient QA. It's still the same. So we have this check here where we're rotating our 2D detector. We have a certain buildup on it, and then we're projecting our plan in a piece of water. Then you're comparing these in particular depths with the measured dose versus the planning dose, and then make a plan comparison between the measured and the calculated one. And then if they agree and the pass rate is good, then the QA passes. Of course, one can argue that this is not in a patient, but this is the point of this is that the delivery was good and that the output of the machine is good. So it has its value. The delivery can also be checked by looking at the spot pattern. This is here. This is the spot position log. So you have the circle indicating where they should be. The green dots are where it actually ends. Here you see the overall delivery. You see there's a systematic shift of 0.5 millimeter, but it's there. But it's within actually a small 1 by 1 millimeter box. So this, and then it comes to the patient treatment. And so we typically deliver in, we now do more hyperfractionation thanks to the CPCT. And it can go up to 39 fraction in case of prostate treatment. The dose also spreads now more between 1.5 gray and up to 7 gray, I would argue. That's what we currently do. So in summary, Proton have some unique dosimetric properties, which can be found useful to producing high conformal dose distribution target and reduce the dose to OIR. Use of spot scan proton has the potential for dose painting with reduced neutron dose. Mitigation of known and unknown uncertainty are essential to achieve a full potential of proton therapy. This remains an active area of research and development. I would like to thank the physics group, the physician, and the dosimetrists, and thank you very much. So, any questions?
Thank you, Professor Falk. We have here one question in the Q&A. And I can read it. Would you think flash radiotherapy will, reinvigorate passive scattering?
The short answer is yes, but there's a long way to go, I would say. So, so the concept is possible, and there are many promising research going on right now, but it's difficult technologically. So we have done flash experiments on our eye line, and as you can see, it's on the eye line, which is a very tiny treatment field. There you can make it work. So what's happening is or it's the same for both. While you can, people argue synchrotron doesn't have enough current and cyclotron is so much better. That's not entirely true. You can create a lot of current in a synchrotron, but of course our LINAC may not be designed for flash. That would be another thing. So if you say I'm designing a synchrotron that's designed for flash, then that would be it. That would work. The main problem is if you flash relies on a very high dose in a very short time, and so you would need to control the dose during this one spill, and that's one of the challenges. So you may have only one spill, and then within a fraction of a second it's done. So that's I mean, there's nothing wrong with it. It's just that the technology needs to be developed and needs to have some research done in this area. But one thing I want to point out, actually, and this is one of the improvements at PTC2, and I'm not sure how much of TJ is the expert for PTC2. He has done the commissioning on the machine, and so one of the big improvement that everybody's saying is the cone beam CT ability. So the making sure that you can align the patient better, and I mean our therapist did a tremendous job for PTC1 aligning the patient on orthogonal X-ray, That works well if you have a disease sites that does that, like, such as head and neck or coronal spinal. But if you have not this disease sites, we're really relying on cone beam CT. So whether this is thoracic or abdomen, so that's where we really need the cone beam CT and the make sure that the alignment is good.
Okay, thank you, Professor Falk. Thank you for your participation. Thank you. So I want to introduce the next speaker, and the next speaker is Professor Thomas Whitaker, who is Associate Professor at the Department of Radiation Physics, Division of Radiation Oncology from the University of Texas MD Anderson Cancer Center. His research interests focus on the outcomes research and knowledge-based planning. This includes novel methods for constructing large data sets, machine learning and deep learning techniques to perform patient outcomes research as well as knowledge-based planning. In a clinic, Professor Thomas has a full spectrum of radiation therapy clinical practice experience, including in proton therapy. Professor Thomas, thank you for accepting our invitation. When you want, you can start.
Awesome. Good morning, everybody, or good afternoon, I guess. With the time difference, everybody can hear me okay, I hope?
Yes, yes, perfect.
Okay, perfect. Let me just switch to my slides. Go into display mode. Okay, now hopefully you're seeing my slides, correct?
Yes, yes, correct.
Okay, perfect. So Falk always does such a great job. I love following Falk because he covers everything really well, but I hate following Falk because he covers everything really well. So we'll look through some of these first slides and we may skip several just because you guys already talked about it for the last hour. I'm really going to try to focus on motion management strategies. Sorry. And so I'll slow down and we'll talk about that in detail, why we do the motion management, how we do the motion management, and some of the key things to think about depending on which modality you've chosen to treat with. But of course, we'll kind of stick mostly to the protons and the concerns with that. I'll try to leave some time at the end as well for us to just have questions and answers. If Falk's staying on, we can both answer those again. I think that's always been kind of the better part of this lecture is getting to ask us questions at the end. So like I said, we're going to focus on the image guidance, and particularly then how we apply that into motion management strategies and some clinical decision that goes into that process. The two centers, Falk's probably already told you all of this. We have PTC1, which we officially treated our last patient. I don't know, I guess 2 weeks ago now. And we're trying to decide what we're going to do. Hopefully we're going to do something great and exciting and something new. The building is still being used, but only just for research at the moment while we kind of figure out what to do on the patient care side. And PTC2 officially opened this year. We treated our first patient. We now have all 4 rooms up and running. And we're treating about 80 patients a day, probably. Our hours are still somewhat limited because Hitachi is doing a final phase of commissioning to give us a continuous scanning system. Right now we have discrete spot scanning, and hopefully in another year we'll be treating over roughly about 120 patients is the goal. So you already talked about the CT simulation, so we'll just quickly go past this. But the first step of motion management is to do your best to fix the patient, and get out any physical movements other than the respiration motion so that you can properly identify the size of that motion. Some equipment that we use that may not be obvious looking at this picture. We don't use this very often, but it is available to us. This is called the bellows. It's a belt that goes around the patient's abdomen and can measure how much the deviation of their belly with their respiration. It's probably my least favorite of devices. I don't find it to be super consistent. But I don't know if you guys, hopefully you guys don't see that. Let me hide it in case you do. Yeah, so I find it the least consistent, but it's very cost effective. So I won't say it's horrible, because if that's all you can afford, it's great to use. But we think there are better and more robust methods. Here in this picture here, you can see there's a tiny little box, and in that box is actually viewed by a camera. And this is a much more reproducible method, and is a method provided by Siemens/Varian, called the RPM system. I think they have a new name for it these days. And then moving even into the future, we have methods in which we can just use the patient's body as a surrogate. So we can just watch it with a set of cameras, and those cameras can watch the surface and know precisely where the surface is because they're like 3D cameras. And we can evaluate the respiratory motion that way. Okay. So Falk already covered this. We use masks, knee things, vac locks. He already did a very detailed view of the treatment planning system. So I don't think that that's something we need to cover in detail. Just, keep in the back of your mind, if this were a photon patient, we would need to use lots of beams. Typically in this modern era, what we're really doing is we're doing arcs around the patient to get nice conformal doses. And then of course the beauty of protons is they stop in the patient, so we don't have to give integral dose to any of the area outside the target, especially when it's superficial like this. All we have to do is get 1, 2, maybe 3 beams on target, and we get a nice homogeneous dose across the patient without any dose to the rest of it. Makes a big difference, particularly in areas like head and neck, where we want to try to avoid dose to the oral cavity and spare parotids. From the CT, we're getting the HU values, and so we're going to use that CT in a variety of ways. Of course, we're going to use it for treatment planning. The HU values are going to be converted either into an electron density or a stopping power, whether we're doing photon planning or proton planning. But then that CT is going to also be the basis for our localization, either through 2D radiographs or volumetric CBCT imaging and localization. Yeah, so like I said, Falk already did a detailed look at the treatment planning, so we will skip past that. To do image guidance, of course, you got to have images, right? So this is a picture of our PTC1. Apologize for not refreshing the images for the new center. But these X-ray sources come out of the back wall in the Proton Center 1, much like the source comes out of the wall for, say, an Electa Linac or a Varian Linac. And then also the the imaging panels, so the detector itself comes out of the wall. Now, fortunately, in the new center, they're actually embedded into the gantry floors and into the nozzle heads. So there's the X-ray panels hang off the nozzle, and the X-ray sources actually shoot through the floor. And the nice thing about that is then we're able to take cone beam CTs by rotating around the patient. We can collect projections every degree or so as we move around the patient, and then do a cone beam reconstruction. We also can take images just a lot faster because we don't have to pull these panels in and out of the wall to get KV images. So if you want to verify your patient's position, then you can just snap an image at any time. And I assume you guys have gotten to see what a LINAC looks like, but I threw in a couple of pictures just for reference. These are standard LINACs for photon therapy. Okay, so kind of the first version of IGRT is just the use of radiographs and bony alignment. This goes back to before we had amorphous silicon imaging panels. We just used radiographic films, and you could take an image using the beam itself, so what we would call an MV or a mega voltage portal. Now, of course, we do this with X-rays. We have special X-ray sources that allow us to do that. And we have amorphous silicon panels to replace the film. So we use digital radiography, and we can quickly get images of high quality. Let's put it that way. And so here's an example of a patient that's not set up well. In fact, they're significantly off. So you can see this does a pretty good job of catching gross misalignments, maybe even small misalignments. It does a good job. And I would say for most things, bony alignment is actually sufficient. So for a head and neck patient, this is often sufficient, especially if we're not trying to treat up here between the eyes, but if we're at the level of the base of tongue and lower down to the supraclav, we're really just concerned about the positioning of the head and the shoulders and the spine. And so using radiographs to align the patient is easy and sufficient. Sometimes you want to track a soft tissue target, like a prostate. And unfortunately, things like the prostate, they move from day to day. They don't move a lot during treatment, although they can. It's just not usually a major concern we have. But for a prostate, the nice thing is we can easily put in these either gold markers or carbon-coated zirconium markers, in which we can then have a dense object to be a surrogate for the soft tissue of the prostate and still use radiographs. So here you can see an image with the radiographs and the fiducial markers, these bright markers. And that allow us, first to set up my bone, but then shift to the prostate in order to treat just the prostate. And then kind of the advancement of all machines at this point, including now our new proton therapy center, we have volumetric imaging. And this can be quite useful for a lot of reasons. So now, like I said, we can rotate all the way around the patient and we can get projections along the way. And those projections can be turned into a volumetric image. That volumetric image lets you do an even better job of setting up to either bony landmarks, but they let you see major changes in tissue alignment, which can be helpful. And then internally, here's a good example of, major changes in rectal filling that may or may not affect the treatment, and we might need to, stop, get the patient down, make an adjustment. It really all depends on what was the status of the patient at the time of simulation and what was the current status now on the cone beam CT. So we look at that, and then we can make some clinical decisions. Okay, so now I want to switch over and really focus more on motion. And so there are different types of motion that need to be considered, and there are different strategies in which we use motion management. And so these are the categories that I broke it up into. I find this, kind of personally helpful to think of it in these ways. And so first we have, I think, the obvious one to everyone, which is just the tumor moves. So the tumor is, somewhere at the level of the heart, or above the pelvis, somewhere in that abdomen, lower lung area, and the tumor is moving with respiratory motion. So motion as we breathe, right? And so then we need to account for that in some way. We can have normal tissue motion. You can have it such that your target is in an area that's attached to the bone, or in an area that is not affected by motion, but yet the surrounding tissues are. Esophagus is a good example of this. Esophagus that bridges between the abdomen and the thorax, such that, part of the target is in the abdomen, part of it is above the diaphragm, and then that diaphragm is moving while the target itself, the esophagus itself, mostly is not moving. And so for protons, this would cause a lot of density changes for us, and we need to mitigate that, but the tumor itself is not really moving very much. So I like to put that in its own category. Then there is mechanical motion, and this has to do with your delivery technique. So if you're doing IMRT or IMPT, in which we have either mechanical MLC moving, or we have the scanning beam moving, we now need to think about that motion of the beam in terms of the target motion, in order to account for any interplay effect. And so we'll discuss what that is in a little bit more. And then the last one that is used a lot, but I don't know that we often really break it out into its own category, is the intentional motion used to separate targets and critical structures. And the classic example here is the heart for left breast cancer patients. So we have patients take a deep breath, and what we want to do is we want to separate the chest wall from their heart, create a space in which we can have that dose fall off and reduce the dose to the heart itself. This technique can be used in other areas. It's just that the deep inspiration breath hold for breast cancer is very common, and usually that's the picture people have in their mind. So we'll discuss that a bit. So once we've identified that we have a tumor that moves, we need to think of, like, how much is it going to move, because that's going to affect our clinical decision making. So kind of in my head, when I'm presented with a patient, I first like to think about where the tumor is anatomically, and that gives me at least an expectation of how much motion I should expect. And so I've put this little scale on our good friend Chris Simeon here to kind of highlight motions that you would expect. So tumors that are in the apex of the lung, really high, almost at the very top of the lung, they move very little. In fact, you can probably expect almost no motion in those patients. Then as you move down to the level of the heart, the motion typically increases and can be greater than 5 millimeters, but are probably somewhat close to that. And then as you move down to the diaphragm, it can be anything. It really is extremely patient dependent. Some patients have, often it's greater than a centimeter, but some patients will have, just a little over a centimeter, where some of them can have 10 centimeters. It's, 10 would be extreme, but it can be large. Let's just put it that way. And then as we move back down, so into the abdomen, we're above the pelvis, but we're moving away from the diaphragm. Again, we start getting less than 5 millimeters. And then when we get down into the pelvis, we're really only seeing motions that are due to rectal filling, rectal gas, or bladder filling. And so these are not usually respiratory motions and are essentially, static, so less than 5 millimeters for sure. But there could be some motion that we need to think about. So we just have to kind of evaluate those patients. Okay. Okay, so once I've done that mental assessment, then we need to, of course, we need to quantify it, right? We can't just say, oh, it's in, it's on the diaphragm. We are going to assume the motion is 5 centimeters. So we acquire a 4D CT at the time of simulation, and then we can assess how much that tumor is moving, and we can decide on a technique in which to mitigate that motion. So if we see a motion greater than a centimeter, we're going to want to do something about it. We have options to simply treat a larger volume. We can gate the beam such that when the tumor goes into a window of the anatomy, we can then turn the beam on and treat during that portion. Or we can use a breath hold technique. This one we need to kind of decide up front and early because we need to get a special scan for this. But we can have the patient hold their breath, in which then the motion should be, reduced to less than 5 millimeters for as long as the patient can hold their breath. And then kind of the last option of mitigation is abdominal compression. And in this case, we take a paddle and we push really hard on the patient until they essentially can't breathe very well. We really mechanically restrict their ability to breathe deeply. And then this fixes it. This is probably everyone's least favorite and most controversial, because there are a lot of us who think this is not very effective. But then there are other people who swear by it. So I don't, it's definitely not my first choice. It's my last choice. But we present it here because it is not an uncommon strategy. So if we want to treat a larger volume, this is using an ITV technique. We've taken our 4D CT and we've assessed how much the tumor has moved. We've applied the appropriate amount of clinical margin, and then we watch that motion over the course of the 4D CT, and we pick a larger volume that encompasses all of the motion of the tumor, so that we treat the tumor no matter where it is in the respiratory cycle. So there's, good reasons to use this. It is easy, effective, and does not require any extra equipment. It doesn't require any special training from the therapists. And so it is an easy solution. Of course, the drawbacks are you now have to treat a much larger volume of healthy tissue than you would have to treat otherwise. And so, we really don't recommend anytime the motion is greater than a centimeter, it's not, the recommendation to use an ITV. It's really only for when motions are less than that. Otherwise, we should try to use some other strategy. But if you don't have any other strategy available to you, and the physician thinks it's safe to treat the necessary volume, then of course that is an option to you. So regardless of whether we use an ITV, there are some things to think about even when there's motion, and that is the motion of sorry, just double checking. Yeah, well, maybe I'll hold the interplay effect just for a minute. Okay, so now let's talk about gating. So in gating, we're just going to let the patient free breathe essentially, but we're going to watch the motion of their abdomen, and we're going to correlate the position of the either our surrogate or the surface of their skin with the motion of the tumor and the position of the tumor within the patient. And then we're going to try to pick some area of their respiratory cycle that is in which the tumor is stable, the tumor position is stable, but the position is there for as longer than other parts of the respiratory cycle. So here I have a kind of a picture of a sine wave, but in reality, it's really much more of a square wave that patients have when they're breathing. And so there's usually a preferred part of the respiratory cycle where the beam can be on for something longer than 3 seconds. If it gets much shorter than that, that patient is not going to be a candidate for gating. It simply takes too long to get the beam on and treat before it would go back off again. And the machines themselves being shut off and on rapidly is not a stable way to treat as well. So when we're doing the 4D CT scan, we're evaluating this respiratory tract and seeing what might be the optimal method for treating a patient. Not to be too vendor specific, there's only a few machines that I think gating works particularly well on without any kind of patient coaching. So I'll just kind of leave it at that. Gating is definitely reserved for very specific machines that it works well on, unless you can coach the patient into kind of maybe a shallow breathing where we can extend this gait out longer than normal. But gating is nice because it provides patient comfort. They don't really have to do anything. You don't have to coach them. Like I say, you just let them sit there and free breathe. And then you manage it all with software. To perform gating, you do need the specialized equipment, right? We either need a camera that watches the box, or one of these gating belts, or the cameras that watch the surface. and then we're going to watch those and turn the beam on and off accordingly. For protons, it's particularly hard because of the low duty cycles. It takes a little bit longer to get a beam on out of a proton machine than it does your regular LINAC. And so that eats up part of your gate time, and then often gating is not really ideal for proton patients. Okay. So now breath hold and deep inspiration breath hold. So to kind of separate these two out for you mentally and how they're used, I think a lot of times we say breath hold for short, or we say deep inspiration breath hold for everything. And I really want to kind of break in your mind that these are two different things used for two different reasons. So breath hold, to just highlight on it specifically. Breath hold, we're simply asking the patient to hold their breath because we want to reduce the motion of the tumor. In a lot of cases, we don't care very much where the patient is holding their breath. But from a mechanical point of view, we need that breath hold to be greater than what their normal breathing pattern is. So their normal breathing pattern should be, down here below this line. And then we need them to take a breath and hold something slightly above that. And that's just so that we can detect whether the patient is in that breath hold position versus their normal position in which we want to stop the beam. So we're going to turn the beam on when they go into the breath hold position, and we want the beam to be off when they're recovering from their breath hold, and we don't want the beam trying to turn on and off. So the reason why this is just breath hold is we don't really care once they meet that minimum criteria how much more they are separating out those two breath phases. Okay. And it's much more comfortable a lot of times for patients to not take a huge breath, but to just create some separation between their normal breath and the breath hold itself. Because our goal in that methodology is simply to have a fixed, reliable position for the tumor and to reduce the amount of motion to less than 5 millimeters, which is kind of then a reasonable application of an ITV. Okay. Now, deep inspiration breath hold. This one, when we use deep inspiration breath hold, now what we're really trying to do is to create that physical space between the heart and the chest wall, or for that matter, any target and critical structure that separates when you take a deep breath. It isn't always, the chest wall and the heart. It is often something like the heart or air cavities, but it could be, a lung tumor and the bronchus to create just a little bit of separation to help us reduce the delivered dose to those structures. Can make a big difference. And then here in this case, we really do want the patient to take as large a breath as they can comfortably and repeatably. So when they do this, we need to make sure that they can hold their breath from 30 to 50 seconds. Anything above 30 seconds is good. Anything less than 30 seconds, then we need to evaluate whether that patient doesn't need a different motion management strategy. 50 seconds is on the extreme side. Anything longer than that, honestly, we're going to encourage the patient to take a breath and recover, because then they start distorting their body in order to hold the breath. And we definitely don't want that, right? That would totally ruin all of our breath hold efforts. So after, about 50 seconds, we're going to go ahead and ask that patient to breathe. So breath hold, again, is a strategy for minimizing motion of the tumor. Deep inspiration breath hold is the specifics of subset when we're trying to create separation, and that deep inspiration is required. So you can use deep inspiration to manage motion, and you can use deep inspiration to create this mechanical separation, but you can't use breath hold to create the mechanical separation. Hopefully that helps. Okay, abdominal compression. Like I said, this is probably my least favorite. It's a lot of people's least favorite, but it does turn out to be sometimes somebody's favorite. And so there's usually at some point a lot of discussion in the clinic as to whether it should be used or not. Some of the reasons we don't like it is it's not as effective as you might think, in that patients can surprisingly still breathe quite well, and there can still be a lot of motion even if you are applying significant amount of compression to the patient. And it also, obviously it distorts a portion of the patient's anatomy significantly because we're having to compress that. Of course, you're not going to treat in the area of compression, but it potentially leads to inconsistencies in the daily setup if there's any variation in how much compression is applied to the patient. It is not comfortable for the patient. Now, patients will go through whatever you tell them they need to go through to cure their cancer. So if that's what you have to offer them and it's important, the patients will do it, but it's probably not the most comfortable way. And so, we really recommend, studying and using other respiratory management strategies. For protons itself, it's not ideal because all of this extra equipment that we can't go through. For a photon beam, if you go through, these frames and things like that, it's really not that big of a deal. It's maybe not ideal there either, but it's not a significant change in dose if you have to treat through the frame itself. But for protons, it is a significant effect, and it just restricts the amount of space we have to treat. So it is an option that can be utilized when absolutely necessary. When would it be necessary? If a patient can't do a breath hold for more than 10 seconds, and it's not really feasible to gate the beam either, then potentially we would look into abdominal compression. That, and there's enough motion there that you have to do something. Because I think our default would be to just free breathe the patient and treat them with an ITV. But of course, there are those situations where the motion is just too high, and that's not an option either. Okay, so from the treatment planning perspective, Falk already covered kind of our newer strategies, but let me just remind you quickly. So up until recently, what we would do is we would apply maybe some density overrides to mitigate areas in which there was significant change in motion, and we would create a treatment plan. And then in sorry. The so then we have like an average scan in which we can create the plan on with stable areas of density, and we'd create our base plan on that. And then if the motion isn't too great, then we're going to try to treat with this free breathing scan. But we can't just assume it's going to be okay, right? We've got to evaluate that. So now, with the advances in treatment planning capabilities, we can actually give the treatment planning computer all the anatomical information up front. We can give them the average scan, and then we can give them the 0 phase and the 50 phase, which are designed to show the extreme changes in anatomy, those 2 phases. And then we can hand it to the computer and have them create a plan that's robust in all 3 scenarios. But if you don't have that ability, it is sufficient to go ahead and create the plan on that average with density overrides where needed, and then just validate that dose distribution on the 0 phase and the 50 phase CTs. And this lets you know that you are going to robustly cover that target in all phases of the respiratory motion. Okay, so now we're going to talk about interplay effect. And so the interplay effect is the interaction of 2 motions. So it's important to kind of keep that in mind. So if you have 1 motion, you don't necessarily have an interplay effect. You have to have 2 motions. And so if we can have our respiratory motion reduced to 0, then we can stop 1 motion and we don't have any interplay effect. Vice versa, if we have a delivery technique that is like a 3D passive beam or a 3D photon beam, we have no moving delivery technique, there is no interplay effect. Okay, it's really only when we have a delivery technique that either has like MLCs that move or a scanning beam that moves with a target that moves, that these now can interact with each other. And the thing we're concerned about is that the beam will be delivering in one portion of the target while the tumor is at the, say the top of the ITV, it'll be delivering up here. And then by the time the tumor gets down here, the beam is also delivering down here. So then we're doubling up the dose on the target, or the exact opposite could happen, in which they're out of sync with each other and we're not delivering to the target at all, right? And so we're concerned about that. The good news is it has been found more or less after about 10 fractions, things tend to kind of wash out and the interplay effect disappears. The other thing we can do is we can use let me see, we can use a technique called repainting, in which we deliver multiple times across this entire ITV. And this is kind of the same idea as extra fractions. So if it takes roughly 10 fractions to make sure you have a homogeneous dose across here, well, we can then take that daily delivery and essentially make sure it treats 10 times by chopping it into tiny little pieces that repaint over and over again. Using that strategy, we can ensure that the interplay effect is not something significant. And that's what you see in these DVHs down here. So here the total MU, or the MU per spot, is 0.04. And so you can see with just one delivery, the tumor is undercovered. But then if we go to 0.005, which again is that factor of 10, essentially, that loss in dose is essentially recovered. Okay. Okay. So let's talk about some decision making. I'll try to be relatively quick and hopefully save 10 minutes for questions, maybe just 5 at this point. Our goal in all of our simulations and our clinical decision making is to make sure that we choose the safest, easiest, and most reliable treatment method for the patient. So we want to make sure that when we're getting ready to simulate, that we know what we're trying to do, what we're trying to achieve, so that we acquire the images we need, but only the images we need. So there's nothing wrong with, say, taking 5 CT scans of a patient if that patient needs 5 CT scans. What we want to avoid is going in unprepared and needing 5 CT scans because we messed up the first 4. So it's really important to have some kind of decision-making process and imaging protocols set up so that you collect the data you need to properly treat the patient. This will reduce their dose in the long run, even if it means extra imaging up front. But we won't be getting any unnecessary scans that are wasted. So I like to use these types of decision-making processes when thinking about simulating the patient and what kind of scans we're going to need. So for liver, lung, and esophagus, again, we're expecting something greater than a centimeter. We definitely want to get ourselves a 4D CT scan. From that 4D CT scan, we're going to be able to assess that motion. If that motion is indeed greater than a centimeter, then we need to decide whether the patient is going to be a breath hold patient or a gating patient, or what our motion management strategy is going to be. If the patient can hold their breath for 30 seconds, then they are going to be a candidate for breath hold. And then we would acquire some breath hold scans. And this would be, typically 3 breath hold scans to make sure it's consistent. Now, it is possible that you could just assume that the motion is going to be greater than a centimeter and simply jump to the breath hold. That is also perfectly acceptable. If it is clear that your patient is going to be able to hold their breath for 30 seconds. But if it's not clear they can hold for 30 seconds, then you kind of need to get that 4D CT to properly assess. If the motion isn't greater, then we have other options now, right? We can treat on the average CT. We can create maximum intensity projections so that we know all of the areas the tumor is going to be in over the different phases, and we can evaluate on 0 and 50 phases in the treatment planning. For breast, and this is just kind of classically for breast, if we see that the heart is close to the chest wall, then we definitely want the patient assessed for breath hold, and we want to try to do a deep inspiration breath hold for that patient. If we're treating a right-sided breast where the heart is probably not going to be in the field, or some patients just have significant space between their heart and chest walls, then free breathing treatment planning is perfectly acceptable. So in the case that we need to do the breath holds, again, we would take the breath holds, typically 3 of them. But if the patient can't hold for 30 seconds, then we just discuss with the physician on how to proceed. It may be that we just cannot create that mechanical separation for that particular patient, but we then proceed on for treatment because, again, curing their cancer is our primary goal. The mitigation is the second, or at least that's the conversation the physician needs to have with the patient, which is we can't spare the heart as much as we want to, but we still would like to proceed to treat your cancer. Then the kind of the last one was the when the target is in an area where the density changes significantly. Here we We'll implement repainting strategies, ideally passive scattering if we can. If we don't, more and more, like currently, we're not treating passive scattered patients. So we need to apply some tricks during treatment planning with density overrides and evaluating on 0 and 50 phase CTs. But these are definitely things we want to assess during treatment, and potentially get a 4D CT scan, but maybe not, depending on how much motion we suspect being there. Okay, sorry for rushing that last little bit, but I wanted to leave us a few minutes to answer some questions, and I will
Thank you,
stop.
Professor Thomas.
You're welcome.
Yeah, now we don't have, thank you for the presentation. It's very important to have in mind, or to know how recent technological advance influence the planning, and influence also the accuracy and outcome for the patient. We don't have any question in the Q&A section. I don't know if someone wants to put a question orally. I don't know. At least till now we don't have any question. I don't know. I have a curiosity. How you spoke about many advances, many strategies. In your opinion, what is the advance that influences more the patient outcome, and also the dosimetry for the patient? So what is the major improvement?
Yeah, I think across the board, a breath hold strategy is the best. Most patients can do it. It does require that a patient can do it. That's the hard part. Not every patient, especially if they have compromised lungs, or if they're obese, their lungs are really compressed and it can be really hard for them to hold their breath. But that strategy, kind of like whether it's a photon clinic or a proton clinic, it's usually the best dosimetry that you can get when the target is moving, with also an increased amount of beam on time. So there's like an efficiency factor, which really helps. So whether you're doing SBRT, things like this, or we're delivering high doses, I really think breath hold is probably the first go-to. So every clinic should probably have done their best to implement a breath hold strategy. Then you have to think about, okay, what is our backup strategy after that? And then if your machine comes on really fast, not all machines do, not even all photon machines, but if that beam comes on like really fast, I think you can entertain gating as an option. It's not usually an option for protons because the beam on time is just a little laggy. There are photon machines, I won't call anybody out, but some photon machines actually are laggy coming on as well. So you have to look at your equipment and decide whether that's a strategy that you can implement easily. A backup for a lot of people then, when you can't just free breathe the patient, is then abdominal compression, where you can force the patient to hold their breath.
Professor, we have already a question in the Q&A section. With the deep breathing technique, what is the percentage of efficiency in the treatment?
Is the question like how much longer does it take when you use deep inspiration breath hold? That efficiency, is that?
I don't know. With a deep, what is the percentage of efficiency in the treatment? Maybe the difference with and without breathing technique, I think, can be the question.
Yeah, so it's probably like, and this is just ballpark, right? I mean, I've never measured it. I'm sure you can look it up much easier than just trusting me. But just ballpark wise, free breathing, of course, is 100% efficient because we just deliver and we don't stop for anything, right? So compared to treating without breath hold, or treating with breath hold compared to free breathing, I would say somewhere between 50 and 75% efficient. So if the patient can really hold their breath, then and you don't need the beam on for very long, then it's very efficient. When the patient struggles and they need significant amount of recovery time, so as tumors get bigger and the patient is having to hold their breath for multiple cycles, that efficiency goes down very quickly because then their ability to hold their breath is reduced as well. And then they need more recovery time. And so then it's probably closer to 50-50. But I would still say that's better than gating. And a gating, I would say, is probably never better than 50% on a proton machine. It's always worse.
Okay. Thank you, Professor Thomas. Thank you for being with us again this year. So now I close this first part, and then we will be back at 4:15.
Nice to see everybody. Goodbye.
Bye.
So, good afternoon, everyone, and welcome back to our second part of the discourse today dedicated to proton therapy. And to start, we will have, as a usual presence in the last editions of this biomedical imaging course, we will have Professor João Seco. He is Professor of Physics at Heidelberg University and also group leader of the Biomedical Physics in Radiation Oncology group at the DKFZ, the German Cancer Research Center. His current research interests are the development of novel imaging technologies to reduce the bragg peak positioning uncertainties for ion beam radiotherapy, and also to investigate the mechanism of radiation-triggered DNA damage via the production of the reactive oxygen species. This year, we have the privilege of having him again giving a lecture entitled Towards Real-Time PGS Range Monitoring in Proton Therapy of Prostate Cancer. So, Professor João Seco, I give you the floor, and thank you so much for accepting our invitation this year. Again, it's a pleasure to have you here.
Thank you very much, Salome. I will start to share, but first of all, good morning and good afternoon. I think there's a mix probably. Let me see if I can... So some of you it's coffee for the early morning and others is coffee for the early afternoon. All right. So as Salome mentioned, I will be talking about prompt gamma range monitoring in proton therapy for prostate. I am presently at home. I hope I will not be interrupted by my kids. So if you see a ghost running around in the background, those are probably my kids. But I apologize right now just in case, okay? All right, so let's get to the topic. So what is particle therapy? So one of the key points of using particle therapy is the bragg peak. But it's not the bragg peak because of the peak itself, but the fact that there is no radiation usually after the bragg peak. So if you have an organ at risk, you have this very low level of radiation afterwards. And you can see that by looking at this picture with the bragg peak and the organ at risk. And if I put multiple bragg peaks together, I can generate what is called an SOBP, so a spread out bragg peak. And with that, in principle, I give less radiation to the organ at risk, and so I get lower toxicity. I can also achieve good tumor coverage if I can control well the spread out bragg peak, and I also give less radiation to the patient because I use less beams. So what are the problems with proton therapy? So the so-called uncertainties. So one of the main problems and the challenges is how we use radiation, proton therapy for radiation therapy. We can use it shooting straight into the tumor, into an organ, or laterally to an organ. Okay? If we shoot straight into the organ, we have what is called an uncertainty in the range. And if we shoot laterally, we also have some uncertainties on the range, not on the range, sorry, on the lateral penumbra. So there are two differences: shooting straight at an organ, shooting laterally at an organ. Usually this one on the left, the one that shoots straight into the organ, is the one that usually creates the largest uncertainties, because if you think about it, the Bragg peak deposits most of the dose. If you put it in the wrong place, you can give high dose or low dose, depending on the organ or the tumor. So here's an example. You have an SOBP. If the SOBP is shifted to the left, then you have an undershootage of the tumor. So you give less dose in this interface area. And if the SOBP is shifted to the right, then you give too much radiation to the organ at risk. And this is a major problem. So we have to be careful where we put this very sharp fall off, which is the so-called Bragg peak of the last one. And this fall off, it depends on many things like stopping power, patient alignment, positioning, setup, anatomy, interfraction motion, and even just organ motion. So what am I going to talk about? I'm going to talk about this range uncertainty problem in the talk. I'm going to talk about motivation for in vivo range monitoring. I will also talk about different types of technologies that are available for range monitoring. Then I will talk about the one we've developed, the prompt gamma spectroscopy, that allows us to both see timing and energy and to get very accurate positioning of the Bragg peak. Then I will offer the results we have obtained with protons at the cyclotron, and also results we've obtained with protons, helium, carbon, and oxygen at the synchrotron in Heidelberg. And then finally, I will give an example of a clinical application, which is the prostate. Okay, so here is the issue. Imagine that you have a tumor right in the center of the brain, the blue, and you have an organ at risk, which is the green, and that's your brainstem. And now I need to treat this tumor with a proton beam. So I shoot a proton beam like that. And so you see the radiation comes in from laterally, and it covers the whole tumor. But if I have a range uncertainty, the dose goes deeper into brainstem. And you see that here on the right, you see the CTV representing the whole tumor, but because I have this uncertainty where the range is, I have to increase my margin, my statistical margin, in what is called a planning target volume, a PTV. And when I increase this target volume, I go straight into the organ at risk A, which in this case is the brainstem. So this is a major issue because I voluntarily give full dose to the organ A, and this is not a good thing. I'm literally creating toxicity when there is none. And that's because of a statistical problem that I don't know exactly where the proton stops. And how big is this margin, the margin that I increase to protect my tumor? Well, the margin depends exactly which center you work at. So there's a variety of margin recipes here. Right? The one that I have right at the center here, 3.5% plus 1 millimeter, was the one that was used in Boston at MGH. And then there is a variety of centers here from Loma Linda to Jacksonville to MD Anderson. There's a variety of centers. And you see that all increase with the depth in the tumor, right? So on the horizontal axis, you have the depth. So you have 10 centimeters deep, 20 centimeters deep. And you see this linear increase from here. And on the vertical axis, you have the range in millimeters that you have to add on. So you see that at 10 centimeters deep, you have a margin of roughly 4 millimeters. If I go to 20 centimeters deep, I need to increase up to 6 to 7 millimeters. And this has a huge variety depending which center is defining the margin. So these range margin recipes have varied significantly between the different centers. And you see this huge window, which is also another problem. So where are most of the tumors that we treat with protons? Well, most of them are usually deeper than 15 centimeters. They're 10 centimeters deep. So 80%, 90% of the tumors are 10 centimeters or deeper. And the colors here represent different anatomies. So the green represents the abdominal region, which allows you to treat deep tumors. The red one represents the thoracic region, and the blue represents the brain and the head and neck. So most of the tumors are more than 10 centimeters deep, where the margins are in the order of 4 to 6 millimeters. So you see here, they're very significant. So you're adding a significant amount of margin here on the top right that you have to induce to allow you to guarantee tumor coverage. So how do we monitor? How do we monitor in vivo range? At the moment, there's a variety of technologies out there, right? Sorry, what is the motivation to monitor? So there is a variety of reasons there. Well, we want to reduce the margins. That's the first thing that you could see immediately. So if I reduce the margins, I reduce the toxicity. I also want to increase my tumor control while also maintaining a low toxicity level. So the red curve here represents the toxicity level. The green curve represents tumor control, and I want to increase this therapeutic window between the green and the red. I also want to be able to do easy quality assurance. So one of the big problems of physics is that we spend half our time in a clinic doing quality assurance, and this is extremely time consuming. So quality assurance needs to be done. And then finally, at the moment, because we have this range uncertainty margin, we cannot shoot straight on to the organ. Because we are uncertain where the edge of the tumor of the Bragg peak is, we cannot shoot straight at the heart, for example. This is the heart, and we're shooting straight at it. Okay, so what would be the goal? So when we develop range uncertainty methods to monitor, we would like to achieve a range below 2 millimeters, right? You've seen that most of the ranges we are usually adding is in the 4 to 6 millimeter range. We want to literally reduce that by half, if not more. So what do we need to do? Well, the key problem is here, the distal edge of the Bragg peak. So here's the Bragg peak from left to right. You see the hot area of the Bragg peak. And the problem is this sharp fall off here is much sharper than the lateral penumbra. So we have to really be careful where we place this Bragg peak, and we want to reduce this uncertainty in finding this Bragg peak. So what are range monitoring technologies? There's a variety of them. There's implantable markers, there's proton radiography, there's MRI, there's PET-CT, there's ion acoustics, prompt gamma, and there's also, most recently, also the dual energy CT, which has also become a way of preventing all these range uncertainties. So these are range monitoring technologies we can monitor inside the room. And then there's also pre-treatment monitoring, pre-treatment planning based on CT or single energy CT or dual energy CT. So the big advantage of the in-room monitoring is that you can see real time, in some cases, what's going on. So the implantable markers offer real time. They are highly invasive, of course. They are not easily available commercially, and the accuracy, well, it depends on how many markers you insert. Proton radiography also offers a form of online monitoring, but it's again non-invasive, commercially available, not available at the moment. Relative to MRI, MRI is not real time, so you have this disadvantage, but you have all the other ones of non-invasive and commercial. PET is also one option, but it's again not real time, but you have the non-invasive part and the commercial available. And another one that was tested for many years is ion acoustics, where it is real time and non-invasive. And the one I'm going to focus this whole talk on is the one that we've developed, or I've developed for the last 10 years, which is prompt gamma imaging. Prompt gamma imaging is real time, it's non-invasive. It is now commercially available, so this is a green tick, and its expected accuracy is probably the best of them all. So that's the one that I focus the rest of the talk on. So what is prompt gamma spectroscopy? Prompt gamma spectroscopy is to use the knock-on information from the particle to the element. So here's the incident particle. It could be a proton, or it could be a carbon ion, it could be a helium ion. It will hit the nucleus of an element. It will excite it, and this excited nucleus then will break up. And as it breaks up, it so-called de-excites. And when it de-excites, it emits these gamma M lines that you can then use them to localize where the Bragg peak is. Here's an example of a patient, for example. You see the beam coming in from left to right, hitting the brain. And what you do with the detector system is that you put the detector system at 90 degrees to observe this. So here on the top right is exactly the same example. You have the protons coming in. You want to detect this final Bragg peak line, and you put a bunch of detectors 90 degrees, and you detect where the signal is coming. And where the signal is more or less correlates directly with the Bragg peak. And when there is no signal, that's when there is no Bragg peak anymore. But what is the major problem with the gammas? Well, we want to measure the blue one. That's our prompt gamma, the ones we want to accept. But the number of them are so small that we have a huge signal-to-noise problem. So the majority of the gammas are the ones that go out of the detector. These we have to reject. Then there's gammas that are produced even in the collimation system. So we have a collimation system that we focus on the detector. A lot of it also produces gamma. And then we also have different types of gammas produced in the medium. And then ultimately, there's also the gammas that are produced in the background. So to really detect the blue one, we need to be able to reject the green one and the red one. And notice that this is like finding a needle in a haystack. This is 1 in 100,000. So every 100,000 photons, one is good. So we have to find a way of rejecting all the greens and all the reds. So we can do a first selection on timing of arrival. So imagine that it takes from the beam entering the room until you observe the signal, that takes a few nanoseconds. So this is horizontal axis is timing of arrival. The beam is emitted at 0, and you see a signal around 4 nanoseconds later. And you see immediately the blue signal is the one we want. The green signal is not what we want, but the timing is very close, and the red signal is the background. So with the timing, we get rid of the red, which is a good starting point. Now we have to find a way of separating the blue from the green, and that we can do based on energy. So now we have our horizontal axis, which is all energy. So 2 MeV, 3 MeV, 4 MeV, 6 MeV, and you see these very characteristic peaks. So these are the energy lines of the nucleus when it de-excites, and these are very particular to the blue. The green will not have these lines, and so we can use the energy lines to separate the blue from the green. And when we do that, we get these very, very particular images which tell you exactly what's going on. So here you have these peaks, which represent different elements. So the oxygen element is this one, the 6.1 MeV. The carbon element is this one, and you see that present also here. There's the carbon element, but now I don't have oxygen because this is plastic. So you can also identify very clearly how many elements you have there and what are the concentrations. And then you have different other peaks, and you have this very long background signal that allows you to calibrate everything. So the yellow blob, the red blobs are your elements one by one, oxygen, carbon, and carbon here. And you have other particular informations from low energy lines. And it's this two-dimensional information, energy on the vertical axis and timing on the horizontal, that tells you exactly where the bright peak is. So how does it work? Well, here's the cyclotron studies that we did in Boston at MGH for many years. In the cyclotron, we have a very unique system that is pulsed. So every 9.4 nanoseconds, you have a small pulse, a few protons that are sent, and between them, there's no signal. And so you have a very unique system that you can use this pulse system to build more or less a very accurate image. And the pulses are roughly a few protons per bunch, between 510 to 100 protons per bunch. Here is the image of the system when we were testing in Boston. You have the proton beam coming in from the left. You have a water phantom that's full of water, and you have your collimation system here, and you have your detection system here that will be detecting everything. And the rest is data acquisition system for all the electronics. So this is what we observe for all the different energy lines. So here you have the different Bragg peaks, but now one Bragg peak is broken up into many energy lines. So the first one up here, the red one is 1.89, 2, 2.3, and so on. And you see the strong ones, the light blue one is 4.4. And you also have the 6.3, which is overlapping with the main Bragg peak. Okay, so 6.1, sorry. The 6.1 is the top one, which is the strongest, the oxygen line. And the blue one is the carbon line, the 4.4. So you see, if you break up a Bragg peak information into different energy lines, you get all the elements one by one. And you see that the peaks also have different shapes. So this is also a very important property, that you see that at the Bragg peak, right at the tip, the elements that matter are the highest energy ones, the 6.1, the 4.4, okay? And the same thing applies to the plastic. So on the left was irradiation of a water phantom. On the right, you have irradiation of a plastic element. And again, you see, here's the carbon line very enhanced. Okay, you don't have the oxygen line, so that's not present, but you do have a very strong carbon line. And how do I detect now where is the range? Well, I just need to measure now 2 points. I measure the point before the Bragg peak, and I measure the point after the Bragg peak, and all the ratios of these elements at each point tells me exactly where I am. So you see, it's a very unique ratio. The ratio of the oxygen line to the carbon line is unique in this point relative to this. Here they are all practically equal, the ratios, but here they're unique. And as I move further away, I have one ratio, and I move closer. So with this ratio, I can calculate the distance to the remaining, to the Bragg peak. So I can very accurately calculate all these different ratios and calculate the distance to the tip. And the same thing applies here on the carbon line. You have very unique ratios between the different lines along this one. And if I know the ratios, I know the distance to the Bragg peak, what is called the residual range. So from the red line to the peak, it's called the residual range, and I can very accurately measure it with these 2 points of measurement. And we did that. We did very tiny shifts of 1 and 2 millimeters, and we could clearly see the shift. So here is the situation where you have no range shift, and the orange line is the one with the range shift. And you see a very accurate shift, very clearly present. Now, when I moved to Heidelberg, I needed to upgrade my crystal, my scintillator, because lanthanum bromide is not a really good crystal because it's naturally radioactive. And so it has a very high background. So what I did is I went looking for a crystal that did not have this high background. So he has the lanthanum bromide, and he has the serum bromide, and the difference is a factor of 15 noise. So you see this huge background of lanthanum bromide is because lanthanum itself is a radioactive element. So we have a crystal which has a radioactive element, which introduces a very large background. So if I replace the lanthanum with the serum, I now have a very, very low background, so I can even have much, much better resolution with very, very low dots. So in Heidelberg, we designed a completely new system based on serum bromide. We also have the timing resolution you needed, and the whole system had to be flexible for different particles, not only protons, carbon, helium, and oxygen. So we designed a variety of tests to test all these elements, right? So we had the proton beam here and the carbon beam as examples, and we tried different materials as targets: water, PMMA, which is the plastic, and we even put elements inside titanium, aluminum, to see if we can see all these elements. And this is more or less the same approach as before, but because it's a synchrotron, it's not a pulsed system. We have to know when the beam enters into the room. So we have to introduce a trigger that basically says this is time 0. The particle has entered into the room. From time 0, I can then calculate the timing until it arrives at a detector. Remember from the previous picture, it was around 3 to 4 nanoseconds. But in the previous picture, because it was pulsed, I always knew where 0 was. But now I need to introduce the concept of 0. I need to trigger every time the particle enters. So we had to build a trigger. The trigger was this kind of scintillator here, or scintillating fibers. And then we have our serum bromide detector here that measures the gammas that come out. So here's the system. You see now a pulse system does not look like this. It's relatively random, the peaks, the height of the peaks, and the amount is very different. And if you have different hits, it also have different sizes. So he has 3 hits, double hit, single hit. So you see that the whole thing is very complex. So the trigger plays an important timing resolution, timing information that you need, so that you also can later on separate the peaks into 1, 2, or 3 hits. And here is more or less the pulse that we see, right? We have the arrival time of background, then you have a huge peak from the prompt gamma, which is the primary signal that you want. Then you have more background related to fragments. These are so-called neutron fragments. These are so-called fast fragments that are coming directly from the head. So what we need to do is remove all this background, which is now noise, and focus on the red line, which is our most important. And you see the timing now is slightly different because you have slightly bigger phantoms. So you still have these few nanoseconds timing, but you have a large background here. And the synchrotron is not every 10 nanoseconds. The pulse structures is usually in the order of 300-400 nanoseconds. So and you have a broad pulse. So here's what it looks like now if you compare protons and carbon. It's again an energy spectrum. Horizontal axis, you have your energy, 1, 2, 3, 4, 5, and 6 MeV. And the vertical axis is just the amount of counts that we measure for gammas. And again, let's look at the high energy. Remember, I mentioned there was a 6.1 line for oxygen. It's still here for protons. The red one is the protons. But you see, for some reason, it's much slower for carbon. So, but the oxygen line is here for protons. And here is my carbon line again for protons. And you see a downregulation of the blue to carbon. But now if you go into the low energy, you start to see the opposite. You see now the carbon produces a lot of low energy lines. And this was a fantastic observation that we noticed over the years, that carbon produces more low energy lines and proton produces more high energy lines. So we could almost distinguish the type of particle just by looking at the energy lines. And the energy lines can be different types of reactions. So you have the boron reaction here, the oxygen 15 reaction, so the nitrogen 14. You have all these different types of reactions that you can measure and very accurately know what it is. And what happens if you add an element to it, like titanium? So we even added elements and we see new peaks arriving. So the red arrows indicate new peaks that appear because of the element titanium. So because of that, we have literally an in vivo spectrometer that tells us what element is present and what are the concentrations. So the titanium has unique peaks that we know, and these are characterized by these peaks that we see them very clearly. So how did we envision the use of this in the HIT facility? Well, the best way to use it is to attach it to the gantry. You attach it to the gantry and then you rotate with the gantry. So every time you rotate, you'll have a detection system that can acquire 2 positions, one before and one after the Bragg peak. and he has the beam coming in from the left. And this makes it a lot easier for them for the application because you don't depend on anything from the floor. Okay, now the key point is how to apply this in the clinic. We developed a clinical protocol for prostate, and we show that it's relatively easy to implement anywhere in the clinic if you want to do it. So the prostate can be treated with different beams. It's very common in protons to use lateral beams for treatment of protons. So here you have a prostate treatment. You have 2 lateral beams. Right? But the big problem of this treatment is the huge toxicity of the rectum. So the rectum is here right in the middle of the beam, and you see a very high level of toxicity, which is unneeded. So in MGH in Boston, they investigated different types of angles for treatment of the prostate. Instead of using parallel opposed beams, they started using anterior obliques. So you see they are coming from the front. They are not parallel, and they are trying to avoid the rectum as much as possible. But you're still going to get a hot rectum. So you have still a high level of toxicity unless you can separate the rectum from the bladder. And there are different ways to separate the rectum from the bladder. You can either use a hydrogel spacer or a rectal balloon where you kind of inflate the rectum to protect it. These are different ways of doing it. So this is standard process to protect the rectum. So what we decided to do is use exactly that, the rectal balloon, but we changed the material inside the rectal balloon from water to silicon oxide. And why using silicon oxide? Well, silicon oxide has a very unique peak in the prompt gamma. So what happens is you have a new peak, the silicon peak. And it's literally visible at 1.8. So roughly here, you just about see it, but I've just amplified it here to see it. You see a new peak of silicon oxide. Now, from the patient perspective, nothing has changed. You have the same balloon that is going to inflate in the rectum to protect it from radiation. But now we have an element inside it that we can see with the range detector, which is the silicon oxide. And of course, if we can see it, that means we're hitting the rectum, and that's bad news. So here's an example of the rectal balloon that we did, a prostate phantom that we added. Here's my prostate. Here's kind of the equivalent of the prostate wall, right? And if you shoot head on, and if your range is inside the balloon, then you're hitting the rectum. That's a bad thing. You don't want to be hitting the rectum. So what we wanted to do is to show that if we inflate this rectal balloon, and with the silicon oxide, we know that the silicon is activated, then we know what we need to do to reduce the range. So that's what we do. Here's an example. You see the beam is coming in. It's inside the rectal balloon, so it's crossing the rectal wall. And that's bad news for the rectum. The rectum is getting full dose of radiation for no reason. But if you pull it back outside of the rectum balloon, or outside of the rectal balloon into the prostate, then you don't have that problem anymore. And you observe literally what happens is the silicon oxide signal decreases until it's 0. So once you have this decrease until it's 0, you know you're no longer in the rectum. So you have an advantage. With the range uncertainty, you can literally pull the dose out of the rectum into the prostate by just looking at the peak, the height of this peak. And you want to confirm that there is no signal coming from the silicon oxide. This was a study that we did in prostate with rectal balloons and a prostate phantom, and we showed clearly that if you pull back by a few millimeters, the range and the prompt gamma system can clearly see that you're no longer inside the rectum. So basically, using a rectal balloon, we can literally spare the rectum to radiation damage. But the rectal balloon has to have something that we can see with the prompt gamma, and that's what we used, silicon oxide. So with that, we also developed methods of doing treatment planning that we can then use to do the best spots to reduce the range and how to pull it back. So real-time monitoring in this method is offered. We show that this can be, you can do real-time monitoring with the prostate. You can very clearly know exactly where the range is and slowly pull it out of the rectum and save the rectum to radiation toxicity. Keep in mind that the prostate is an important organ to treat, but it has severe toxicity if the radiation is all given to the rectum. So final conclusions. The prompt gamma has demonstrated the first time at the HIT in the synchrotron facility. We did an extensive amount of studies showing it is feasible. We developed a prototype for preclinical prompt gamma spectroscopy that is installed for the HIT if they want to use it, of course. We are able to resolve single particles within a bunch with our timing system, which has very, very accurate timing resolution. We observe variations in oxygen and carbon inside the target, so we can even measure oxygen and carbon and evaluate if the tumor is hypoxic or not. And we've achieved real-time range monitoring for the prostate, which is the first time anyone has done that with prompt gamma. And that's an old picture of all my group, and the people that did the work are no longer working with me, but I still have to acknowledge the fantastic work. Paulo Martins, which was my postdoc, he's standing here, sitting here, sorry, this is Paulo, and his PhD student, Ricardo Dalbello, which is here. So the two of them are the ones that did the most amazing work during the 3 years with me. And a lot of the work is also in collaboration with the Max Planck from the Research School of Quantum Dynamics. And I have also special thanks to several people from the HIT facility. All right, thank you very much for your attention. I'm open to questions if you wish to ask any questions. Let me stop sharing maybe.
Thank you so much, Professor João. We have, in fact, a little bit more time for the discussion. So for now, we don't have any questions yet. I have one question, and I'm sorry if it's not, in fact, applicable, but you can tell me. Regarding the detectors of this technique, would photon counting the detectors could be an option to improve the detection efficiency of this technique in case we need to increase detect those specific gamma rays? So could this be an improvement?
So photon counting detectors are really good at low energy, like below 100 keV.
Okay.
We're looking for 1 MeV or higher, and some of them are 6 MeV. So they are very, very high energy. It's like stopping. Let me just give you an example. Take a bus and a 747 Boeing. You put them at full speed. The bus you can stop within, say, 50 meters. The Boeing you will take many, many kilometers to stop.
Okay.
So the difference in energy is so huge that you need a huge detector that has the power to stop it. And the scintillators that we use are very, very dense and very big. So the photon counting would be great to count photons, but the energy resolution would be would not be ideal. I mean, unless I go below 100 keV, of course.
Okay.
Most of the photons we're looking at are above 1 MeV, so they're not. They have very high energy.
Okay. And do you see an application in the near future to another types of cancer, or are you performing any studies in different types?
So we're using prompt gamma for in vivo dosimetry now because it has the ability to measure directly all the elements. I can also measure the amount of radiation I'm given instantly. So I have also the timing information. So if I change the radiation timing, I can see it. I see signals.
Okay.
So I won a big German grant to use the prompt gamma to do in vivo dosimetry. So I can basically look at the patient pulse by pulse and tell you how much dose is delivered. So it's not only the ability to see the range, I can see the dose also, which is much more a bigger problem. The in vivo dosimetry has always been a major problem.
Okay. Thank you so much. For now, we don't have any more questions. So, but you let us with your contact. So if anyone has a question, maybe do it later. So as we are a little bit advanced in our program, I will suggest and the break was a little bit more short than usual. So we will have another break. Also because the next speakers are not here yet, so we will have a break and we will be back at 5:15. The time for which the presentation of the UT Austin Portugal projects are scheduled. So we will be back in half an hour, more or less. So welcome back. We will start this last session of today, and we will now have a different session from the previous one that we are used to in this biomedical imaging course, which will include the presentation of 3 projects financed by the UT Austin Portugal program, namely in the thematic area of medical physics. This program, the Austin Portugal program, supports projects that are developed in collaboration with the UTMD Anderson Cancer Center from the United States. And to start, I will present the three speakers, the three next speakers. They will give us an overview of the projects that were developed by their teams, and then we can make a discussion at the end. So we will start with the first project entitled AT&PT, Automatic Treatment Planning for Proton Therapy, whose the PI in Portugal was Professor Joana Dias, Associate Professor at the Faculty of Economics of the University of Coimbra and the researcher at INESC Coimbra. The second project, the TOF-PET for proton therapy, will be presented by Professor Stéphane Tavernier. Sorry if I misspell it. Professor Stéphane is full professor in Brussels and also vice president of PET-CIS Electronics. And to finish this session, we will have Dr. Célia Fernandes, who is principal researcher at the Department of Nuclear Sciences and Engineering of the Instituto Superior Técnico of the University of Lisboa, presenting the TER-PBCT project, a theranostic strategy for proton boron captured therapy of pancreatic cancer. So, as usual, all the participants or the speakers are free to ask questions on each other in the chat or in the Q&A. And in this session, we will have the discussion made at the end of the three presentations. So I would like now to reinforce our appreciation to the three speakers. Thank you, Professor Joana Dias, Professor Stéphane, and Dr. Célia for being with us today, sharing your experience in developing all these projects that all are finished by now. So we are excited to hear from you and from this investment from the program in your projects. Thank you so much for the three of you. Professor Joana, you can start whenever you want.
Thank you so much for the invitation. I'm going to share my screen with presentation. Are you all seeing my presentation?
Yes, perfectly.
Okay. So I was asked to talk about the project that we had. It has already ended. And actually, we had this project in a very demanding time because the project began more or less at the same time as the pandemic. So we had some plans that we could not pursue because it was not possible. One of the things that we would really like to do was to go to Austin, to go to Texas and see the MD Anderson Cancer Center, and that was not possible. But even so, the collaboration was great, and I'm going to talk a little bit about what were the objectives of this project and what we achieved. So our project, we were really, really very fortunate because we were able to count with the participation of Professor Mohan. He was the PI at the Austin side. I was the PI here. And we also had two more researchers here in Portugal, two more researchers in the States. So here in Portugal, we had Humberto Rocha and Vigida Ferreira that were in this project with me. And in Texas, we had also Wen Wakao and David Grossens that were working with us. So basically, what we wanted to do with this project was to consider automatic planning for proton therapy. So basically what the biggest objective of this project was to be able to reach a solution that would contribute to automated treatment planning solutions so that we could really have very good treatment plans using proton therapy in an almost automated way. And basically in this team, we were very fortunate because we were able to have a really interdisciplinary approach because all of us researchers, we have different scientific backgrounds. So we were able to join together researchers from medical physics side, but also computer science, operations research, and medical oncology. So why is this problem challenging? So why is it interesting for us to study treatment planning in proton therapy? Basically, nowadays, even with the advent of many recent approaches and solutions, some of them based on artificial intelligence, for instance, even with all these recent advances, radiotherapy treatments still rely on a trial and error planning procedure. So we still have the human planner that is the main responsible for assuring that a very good quality treatment plan is planned. And this is still a very hard work for the human planner, even with all the tools and with all the help that nowadays exists. And proton therapy is especially challenging. And one of the things that makes proton therapy very challenging is that it's very, very appropriate for treatment of cancer. It has some very, very good qualities, some very good features that I'm going to talk a little bit right now. But it's also very, very vulnerable to uncertainties. So much more vulnerable to uncertainties than other treatment modalities. And this increases the complexity of treatment planning because treatment planners don't have to be only looking at having a very good treatment plan. They also have to assure that they are planning a treatment that is robust. Robustness means it's a treatment that will work very, very good even under an uncertainty context. So basically, this project was about developing robust mathematical models and optimization algorithms that could explicitly deal with all these uncertainties and be able to, in an automated way, improve treatment quality, providing very good treatment plans. So why is this a problem? So basically in proton therapy, we have the machine that is responsible for the radiation. We have the patient that lays down in a couch. And there are many, many decisions that have to be made. We have to decide what are the angles that we are going to use in the treatment. And we also have to decide how we are going to irradiate. And so basically, we want to have all the volumes to treat very well covered, but we don't want basically to ruin anything else. So we want to maximize what we are doing with the planning target volume, with the volume that we want to treat, but we want to spare as much as possible all the other tissues, all the other normal tissues, especially what we call organs at risk. So all the organs that are in the path that we cannot avoid irradiating, but we want to make sure that they are still totally functional organs and that we minimize as much as possible all the possible side effects of the treatment. So why is proton therapy so adequate for treating cancer? Because protons have unique properties that make this kind of treatment modality completely different from other, for instance, photon-based therapies. Protons have what we call the Bragg pit. So an area, a point, if we can say so, where maximum dose is being deposited. And if we are able to place these Bragg peaks correctly, basically, if we can say this in a very simple way, inside the volume that we want to treat, then we are able to have very, very good results in terms of tumor and spare very, very, very well all the other tissues. As you can see in this graph here, one of the things that makes proton therapy very, very different from, for instance, photons, is that in photons, we have a dose that is decaying as we go through the patient. And basically, it's not possible to have, not to have an exit dose. So basically, we are hitting the tumor, but even so, some dose goes beyond the tumor that we want to treat. With proton therapy, if we are able to really place very well these Bragg peaks, what we have is a very low dosage being deposited until the Bragg peak. Then we have this very, very concentrated dose all the effect that we have is concentrated in the tumor, and we basically don't have an exit dose. So we can be very, very precise in terms of the dose that we want to give to tumors and sparing very, very well all the other tissues. But this comes with a problem. There are many, many uncertainties, and there are more uncertainties in proton therapy than in other treatments. Basically, a radiotherapy treatment takes place during several days or weeks. So basically, it's not possible to assure with 100% certainty that the patient is really always placed at the same position with no kind of interference. Basically, what is the ideal situation is that the patient is positioning in each day of the treatment exactly as he was positioning when he took the planning CT, when he took the medical image that basically is the base for all the treatment plan. But actually, it's not possible to guarantee this with 100% certainty. There are always some errors in positioning. We can be talking about errors in terms of millimeters, 1, 2, 3 millimeters, but they are errors in patient position. And of course, most of the organs, they also move. And there are also changes in our internal organs. So it's also not possible to assure that in every day of the treatment, the organs are exactly in the same place with the same volume, exactly the same as when this planning CT was taken. And of course, there are movements that are inherent to a patient, like breathing. So there are things that all in every day of the treatment are going to be a little bit different than what is considered in this planning CT. And in protons, we also have range uncertainties. So basically, we cannot be totally sure where is the positioning of these Bragg peaks. Okay, so there are also some range uncertainties that we have to account for. Why is this a problem? Basically, it's like having a very, very potent weapon and not be able to know for sure what is the target. Okay, so if we are hitting the target as we want, if we are hitting the tumor, then we will have very, very good results. But if we don't take into account uncertainties, then we can think that we are hitting the target, that we are hitting the tumor, but we are not. And if things go very, very badly, we can even be hitting an organ at risk instead of hitting the tumor if the organ at risk is very, very close to the tumor. So basically, it's like trying to hit a target, but the target is moving. Okay, so we cannot be totally sure where the target is in every single day of the treatment of the patient. So what we wanted to do was to consider these uncertainties, all of them, in an explicit way when we consider our automated models and algorithms to produce a very good treatment plan. So basically what we did was to develop an approach that takes explicitly all these uncertainties into account and tries to make sure that the treatment plan is robust in the sense that it will be able to deal with all of these things. So basically what we developed was an automatic robust fluence map optimization approach. So in this project, we considered the angles as being fixed. We have not considered the optimization of the beam angles. We consider them fixed. And we focused on automating the fluence map optimization. So basically optimizing the way in which we position the Bragg peaks. And what we did was to consider in a simultaneous way a set of scenarios. So we consider that all the organs at risk and all the volumes to treat, because we can have more than one volume to treat at the same time. So basically all of the structures of interest that you can see delineated in different colors in those CTs, what we considered was different possibilities for their positioning, for their overall volume. So basically we simulate the different scenarios that can occur and we consider them simultaneously into account when we are doing a treatment plan. So basically, instead of working with the original set of structures that are delineated in the planning CT, we increase a lot the number of these structures to account for different possibilities of uncertainties that may be associated with all of these structures. And we also consider different possibilities for the range uncertainties. Then we consider a very simple model for fluence map optimization. There are many mathematical models that are used and that are known from the literature that allow us to do this optimization. We decided to work with one model that we have been working for a long time. It has a big advantage. It is what we call a non-constrained optimization problem. It does not have any constraints. It's only an objective function that we want to minimize. And it basically considers what is the dose that is being deposited in a given structure, and also lower and upper bounds associated with these structures. And these lower and upper bounds have to do with our medical prescription. So what is the dose that we want to give to each one of these structures, or what are the upper bounds that we must not surpass. And we can also have different importances, different weights associated with each structure. So one of the problems of this model is that we have to a priori determine these parameters. These weights, these upper and lower bounds, we have to a priori determine them. And this can jeopardize the quality of what we are going to achieve at the end. So what we did was to create a fuzzy inference system. A fuzzy inference system is basically a set of rules that we can represent in a mathematical way, but that these rules can represent the concepts that we use in our natural language. For instance, we know that when a human planner is planning a treatment, imagine that there is a given structure that is not yet achieving the result that the planner wants. Imagine, for instance, that we have the volume to treat, and the volume to treat is not yet receiving the dose that it should be receiving. So what the human planner does is to increase the importance of this structure within the optimization. The human planner needs to tell to the optimization algorithm, please be sure that you give more importance to this structure, because this structure, this PTV, this planning target volume, is not yet receiving the dose it should be receiving. And basically, the changes that the human planner does in all the parameters associated with this structure have to do, usually, to the distance between what the treatment plan has now and what I want to achieve. So we defined a very simple set of rules, as simple as this. If I am very far away from achieving what I want in a given structure, then I have to change the parameters associated with this structure very much. So if I am a long way from what I want, I have to have a very expressive change in the parameters. But if I'm if I'm really achieving what I want, I am very near what I want, then I just have to make a very small change in these parameters. And these human concepts like being far away, being near, changing a lot, changing by a very small amount, we can represent these concepts using fuzzy logic. And we can integrate these concepts with these rules and build what we call a fuzzy inference system. So basically, we developed this fuzzy inference system that automatically does this parameter selection for that very simple unconstrained optimization model. And with this, we are able, even with an enlarged number of structures, remember that to explicitly account for uncertainty, what we do is to not use only the structures that are delineated in the CT treatment medical images. Basically, we enlarge this original number of structures by considering that one original structure can now be 4, 6, 7, 10 times that original structure because we are considering very different scenarios that can occur with that structure. So we have a very, very large number of structures that we have to deal with in an explicit way. And with this fuzzy inference system, as it is a totally automatic procedure, we are able to find admissible treatment plans in an automated way. It would not be possible for a human planner to simultaneously account for such a large number of structures during treatment planning. Another thing that is very, very important when we are dealing with uncertainty is that the way in which we assess the treatment plan has also to account with the existing uncertainties. So what we did was to use Monte Carlo simulation to see what the treatment plans that were being calculated are capable of. Are they robust? Are they not that robust? So basically, the assessment considers looking at DVHs, looking at those volume histograms. Those volume histograms gives us an idea of how the dose is being deposited in each one of the structures of interest. And in those volume histograms, basically we have like this band associated with each structure, and we want this to be as narrow as possible. And of course, there are then many, many statistical analyses that must be made to understand whether the medical prescription is being satisfied or not, if there are deviations, and obviously to compare this approach with other existing approaches. So using Monte Carlo simulation, we basically have a lot of data that then we can use and treat with statistical analysis. Actually, this project was very, very good because all the work that we did during the project is still going on. So our collaboration has not stopped because the project stopped. So we are still connected with the MD Anderson Cancer team, and we are still working together. So basically what we are now doing is to consider also beam angle optimization that we did not consider during the project. We are also considering other things like very specific to proton therapy, like variable RBE. We are also trying to understand what is the impact of the number of treatment fractions in uncertainty, because we know that, for instance, in photons, increasing the number of treatments is good in terms of uncertainty. And we are also seeing what this means to proton therapy. And because we are working with mathematical optimization problems that have some initial parameters and have this set of fuzzy inference rules that also have some parameters, we are now including reinforcement learning to speed up the optimization process. So basically, reinforcement learning is a way in which we can increase our knowledge of how to better optimize a problem, given the information that we have from past problems that we have solved. So we are now also including this reinforcement learning aspect, not to improve, but to speed up the optimization process, so to make everything run a little bit faster. Why was this UT Austin Portugal project so important for us? We don't have proton therapy in Portugal. So without this program, it would be very, very difficult for us to have access to a clinic where proton therapy is being delivered. So it was really an opportunity to work with one of the best cancer treatment institutes in the world. Professor Mohan is an excellent, excellent, excellent person to work with. And it was really a great opportunity to work with leading experts in the field. And it was very, very good because, as I told you, collaboration is still going on even after the project has ended. So this was really a very, very, very short summary of what we have done. If you have any questions, I'll be more than happy to answer them at the end. And if you want to contact me, you also have here my email. And I will also be very happy to answer all your questions. If you want more details, please feel free to contact me by email. Thank you so much.
Thank you, Professor Joanna, for this very clear and very nice presentation. We will now move on to Professor Stefan.
Yes, but how do I get my talk available?
You can share your screen.
I can share my screen. Share,
Yes.
yes. And what do you see now? Do you see?
Yes, but also with your desktop. And yeah,
this?
now in presentation mode, it's perfect.
Yeah, except that I'm at the still get to the first page. Okay, so so you can see my screen. So thank you.
Yes, we just cannot see you now.
Well, I don't know what I should do that you see me. No, yes, probably like this. So you see me now?
Okay. Yes, yes.
Okay,
Thank
good.
you.
So thank you for inviting me to give this presentation here. And so you see the title is Proton range verification in proton therapy. And hold on, now why is not going to the next page? It doesn't I? Okay. So first, okay, so does it, yeah, it works like this, good. Okay, so brief in a few words what I'm talking about. The UT Austin Portugal program approved a project in-beam time of flight positron emission tomography for proton range patient therapy, and I will report on the motivation and the status of that project. So this was a slide to explain the situation in proton therapy, but the previous speakers has explained it very well, and I cannot add very much on that, so we save time and go to the next thing, which is that she has mentioned several sources of uncertainties in the radiation therapy. Now, one of those uncertainties is the range of the protons. So you have an image, CT image of the patient, and you shoot the beam and you want to get a certain depth in the tissue. Unfortunately, you cannot easily calculate with precision this distance because a CT image is based on attenuation for gamma rays. The stopping power for protons is something different. And from the CT image, you cannot really accurately predict what will be the range of a proton of a given energy. So you don't know what energy you should use to get where you want to get. Now, if you knew the composition of the tissue very accurately, of course, you would calculate it if you have the stopping power for gammas, but you never know the composition of the tissue very accurately. Just to give an example, how much water is there in the tissue? That can vary depending on all sorts of things. Maybe the previous irradiation of the previous session has resulted in more water than you think. So there is an uncertainty which can be significant, too big to ignore. So it would be desirable to try and measure that range. Now, it is indeed possible to measure that range because the protons, when they travel in tissue, they ionize the molecules, and that introduces radiation damage, and that's what, of course, is used to kill the tumor cells. But those protons also will sometimes induce nuclear reactions. And in those nuclear reactions, secondary particles are produced that you can observe. And from that, you can observe the beam. Now, there are several reactions that are possible, and I've listed here in order of, probably in order of ease of use. Now, from gamma rays, so you can have a reaction where you produce a high energy gamma ray, and prompt means that gamma ray is emitted instantaneously. Well, it means within nanoseconds of the interaction. Then the next thing that you could try is positron emission tomography, because the interaction of the protons could produce isotopes that are positron emitters. And then within a short time after the beam passed, you could observe those positron emitting isotopes in the same way as you do in PET scanners, say a few words, later about it if you're not familiar with that. Now, there are a few other things that you could try and do, but to my knowledge, the other things have not been studied very much and a priori do not look so promising. So I will concentrate my discussion just on the two first cases. So let's go to the case of prompt gammas. Now, the advantage of prompt gammas is that you can observe the range of the beam with prompt gammas with a fairly simple geometry and setup. So here you have a drawing where you would see the beam, and then you would observe gammas by placing a collimator. I don't know if you see my pointer on the screen. Do you see my pointer? Okay, well, anyway, if you see it or not, I think you see there something that you see the pointer. So I'm pointing at this object there, and this is basically a collimator. That's a heavy piece of metal, usually lead or tungsten, and a small slit, and that piece of metal is thick enough that it stops all gammas except the small slit where the gamma rays go through. And then you put a detector of gamma rays behind it, and obviously you will see where the beam stops like that. So the advantage of this is that it is relatively simple, and to my knowledge, the system that is actually now of doing it. Now you could try and use the positron emitting isotope produced, and just one slide on positron emission tomography. For those of you who are not so familiar with it, it's a well-known technique in medical imaging where you inject the patient with some molecule which, for one reason or another, is interesting to study, and you have labeled this molecule usually with fluorine 18, which is a positron emitter with a half-life of 110 minutes. So the patient is injected with this molecule, it distributes in the body, and then you can observe the distribution of the molecule in the body by observing the annihilation of the positron. So this fluorine 18 emits a positron. The positron in the human tissue within a very short range will annihilate with an electron and produce two gamma rays of 511 keV that go out of the patient. Well, sometimes they're stopped in the patient, but at least sometimes they leave the patient in exactly back or nearly exactly back-to-back directions. And if you detect those two gamma rays, you know that the molecule was somewhere on the line joining those two detection points. And from a very large number of such annihilations in all directions of space, you can reconstruct the three-dimensional distribution of this isotope and therefore of the molecule that you're interested in the body. Now, this principle can be used in case of proton range verification, because the proton beam produces several isotopes that are positron emitters. It produces, and the most important one, important means that most abundant isotopes, there are more, but there are very few of them. So there the carbon-11, which has a half-life of 20 minutes, and oxygen-15, which half-life of 2 minutes. So if you have a beam, those positron-emitting isotopes are produced, and if you surround the patient with some sort of PET detector-like detector, you can visualize the beam and see the beam where it stops. If you difficult, that can you really need a full. It is better not to have a full ring, but in case of proton therapy, fulling is difficult because of course you have to provide the space for the beam, and the beam not just a small hole, because the beam may have to scan the volume and so on. So you need large openings in the range to do that, but there are ways to in that case. So it's a complication, but not a showstopper. So here I show you a simulation of what happens when a proton beam enters a tissue, or rather in the simulation, it was simulated of the proton beam is traveling in a kind of plastic PMMA. Now that's a plastic which is very similar to human tissue, and that is always used for this kind of studies. So in this image, you see the gray thing that is the radiation dose that is deposited in the tissue. And as you can see, it is a certain radiation dose. And at the very end of the beam, the dose is the highest. And then where the beam stops, it really stops abruptly. The other curves in color one are the positions of the positron emitting isotopes that are produced along the beam. Now there are the several isotopes, but of course when you observe the beam you don't know which isotope has produced it, so you basically should only look at the sum, which is the sort of pale red curve. And as you can see, you indeed have positrons emitted all along the trajectory of the protons, but before the proton stops, actually the cross-section for producing positron emission drops to 0. So that basically, if you measure, you do not measure until the end of the proton beam. You are missing a few millimeters. You can see here where you would say, okay, I go at halfway of the maximum, I say there the beam stops, and actually the beam stops about 5 millimeters further. This is a complication, but again, not a showstopper, because this kind of gap of the order of 5 millimeters is perfectly predictable. And so you can correct for that. So you can observe the beam using those positron emitters, but then you have to know that in reality the beam goes of the order of 5 millimeters further. The exact number depends on which tissue you are in and so on, but it's something that can be calculated. Now, it may be useful to point out that you have the same problem in case of Prom gamma emission, where you see again a blue curve, which is the range as you would measure it with Prom gammas. Now, it may look better on this figure, but that's only because the scale is different. Right here, the full scale is 5 centimeters, and in the previous figure, the full scale was only 6 centimeters. So that's why the curves, they look closer, but they are actually quite similar. So you have exactly the same problem, and it's not either advantage or disadvantage of one method rather than the other. So let's look at advantages of using PET compared to Prom gammas, at least the simple Prom gammas technique. Now, first of all, PET is a well-established technique, and the problems of image reconstruction in PET and so on, all are perfectly known, and so we are. It's more complicated than the Prom gamma, but it's things and problems that are well known. So that is one of the reasons why we look into that. So one rather obvious advantage is the simple Prom gamma detectors. You have a very small solid angle, only a very small fraction of the gammas, the ones that are exactly in this very narrow slit, are detected. While in PET, you can cover a large fraction of the solid angle around the patient, and so you will detect more events for a given number of protons. So basically, you need less protons to know the range of the gammas with a given precision. Another reason is that PET allows a better spatial resolution. 1 millimeter spatial resolution in PET is a very feasible target. Prom gammas, at least the simple method, I don't think that would be possible. Another thing is that PET has more information. You have completely. In the Proton gamma, you measure the endpoint, that's it. So it's certainly an advantage that you have this much more information. Now, maybe it's possible, I'm not sure how realistic that is, but in principle, at least, you could give the patient a marker that will make the tumor visible, and you could then see in the same image the tumor and the beam and be really sure that you are where you are. Now, again, may not be so simple to do that, but in principle, I think that's something that could be done. Another advantage is that with PET, it's relatively easy to have markers that you some weak positron emitting sources that you put on certain places in the body of the patient, and that would also be visible in the PET image and would help you making sure the position is correct. Now, admittedly, there are also a few drawbacks, and one obvious drawback is that in Proton gammas, the beam is there and the gammas are there immediately, and you have the data immediately. In PET, of course, you have to wait for the positron emitting isotopes to decay. Now, the oxygen 15 is 2-minute half-life, so you have not to wait that long. The carbon 11, you will have to wait much too long, so you will just not wait so long and lose part of the events. But that's certainly a complication compared to Proton gammas. Another aspect is that PET will certainly be sensitive to the background from the proton beam. It's probably difficult, if not impossible, to record the PET data while the beam is on. That means you would have to irradiate, stop the beam, record the PET events, the PET image, and then continue. Now, this is not such a big problem as it may look, because in many installations, and in particular in MD Anderson, anyway, the beam is stopped. Typically, you have a cycle that depends on the details of what you want to do. Typically, you have 1 or 2 seconds with a repeat. Well, it's a complication, but it's not a showstopper. One should also be aware of one phenomenon that if you wait, then the positron emitting isotope that had been produced could move, because they could be in the blood and circulate, so you should not wait too long. Now, if you wait 1 or a few minutes, it's probably okay, but you should not wait 20 minutes, for example. Now, people have proposed to move the patient from the radiation place to conventional PET scanner, but that is not really a good idea, mainly because of this problem of washout of the irradiation. You really have to have a PET scanner that's on site where the beam is, and you can immediately take the PET image after some irradiation. So basically, that is what the project is about, is to build a PET system that is suitable to be used on site in the Proton radiation facility and can be situated. So this is a collaboration, as in the previous project, between a number of teams in Portugal and a team in USD Austin. I have put a picture of our collaborator and co-PI at UT Austin, Carl Lang, and I had a very pleasant collaboration with him. He is an able and pleasant person, so that's always nice to have. And so basically, so basically, we want to make this test detector and make sure it's a realistic detector that could be used for patient studies, but we did not plan to use it for patient studies because we don't think that was realistic in the time scale of 2 years of the project. So we but the detectors are still there, and maybe in the follow-up project they could be used or whatever. So to go a little bit more into detail, so we have on the left in this picture, you see what the layout is. It should be in the proton beam facility. So you would have the detector we propose to use would be a detector that would be optimized for use for irradiation in the brain. That obviously because that is a small detector and so less expensive and in a number of ways easier. In this picture, we have shown the situation where you have, you see what the patient would be. You have two partial detectors with big gaps too low for the beam. And in this picture, the beam would come from above. Now, this doesn't need to be from above. The beam can come from any directions. Then only those detectors would have to rotate, which is perfectly possible. So this is something that could be used in a real scanner. Now, on the right, you see the real object. So you see the detectors as they really exist and not in the beam, because in the beam and in the radiation facility, we cannot leave the detectors there. They can just be there for the test for a small time and have to be removed immediately. So that's how the detector is in the laboratory there at UT Austin. So you can see those two detectors. It's like, it's approximately not quite 2 times a quarter hovering. It's a bit more than 1/4. And below the electronics that is there to take the data. Now, what is this? No. Okay, so here you see a little bit more details of the PET detector. So to the left, you see the PET detector with the covers removed. And so on the right, you have more detail of how the detector are. So this is fairly standard for PET. This is as PET scanners typically are made. So you have an array of LYSO crystals. These are crystals that have a high stopping power for gamma rays. And when a gamma ray interacts in a crystal, it produces a light flash. And then this arrays of scintillating crystal is put on an array of photodetectors, a silicon photomultiplier. So you see there an 8x8 array of photodetectors. These are small photodetectors. When you see a flash of light, they produce a small electrical pulse that goes to some electronics that detects the pulse and then records all gamma interactions in this way. The detectors exist, the whole assembly is made, so we tested and we are now fully confident that the PET detectors are working. So I'll show you a few measurements to illustrate that. So one first measurement is the energy spectrum. Now, what the energy spectrum means, so this is done in the beam and just after the beam. So you put the detectors there, you put the beam on, and you stop the beam, and then you continue to record what you see. And then in each detector, you will see whatever pulses this particular detector has seen, and you make a plot of the pulse height. Pulse height, this means the amount of light, because the energy of the gamma ray is related to more or less linearly related to the energy of the gamma ray. So this is kind of a plot of the pulse height that each detector sees. Now, on the left, you see what the spectrum is during the irradiation, and you have spectrum, which is basically background. There's all sorts of interactions generated by the beam that produce gamma rays and maybe other particles that can interact. And you doesn't look that it would be easy to find the gamma interaction of 511 keV in there. But as soon as the beam is stopped, so just after the beam, the spectrum becomes completely different. And there you see a prominent peak, and that peak can be shown to really correspond to gammas of 511 keV that must come from positron annihilation. and some background that we also understand where it comes from, but that is at a completely manageable level. And this is what we should indeed see. Now, one property that is very important in a PET scanner is the time resolution, because how do you have 2 gammas of 511 keV, but you must be sure that those 2 gammas come from the same positron annihilation, are not just 2 independent annihilations that by chance come at the same moment, and you think they come from the same annihilation. Now, the only way to do that is to measure the time of those gamma rays with a very high accuracy, so that the probability that by chance, by bad luck, you would have 2 unrelated gammas that come at the same time becomes negligible. So here you see the plot on the right side is the time difference. So you have all those spectra of the pulse height that you see. You select events that have an energy deposition that corresponds to 511 keV, and then you look for all combinations of detectors where you have within a small time window some coincidence. And if you plot the time difference for one particular pair of detectors, so you have all sorts of detectors and all sorts of combinations of detectors. So you just in the picture on the right, you have taken coincidences between one particular detector and one half detector and another, and you plot the time difference, and you see a very clear peak. At the time difference, it is close to 0 in nanosecond. And from that, you get, for this particular pair of gamma rays, coincidence time resolution. The different pairs have different coincidence time resolution. So in the plot on the left, I have considered a very large number of pairs of detector elements, and for each of them I have determined the coincidence time resolution through our maximum, and you see you have the distribution, and the mean is about 0.230 nanosecond. Now this time difference corresponds to a travel distance for light or gamma ray or just visible light of about 7 centimeters. So it is really a very accurate time measurement, and in this case more than enough for what we need to have. In addition, this good time resolution helps in solving the problem that we do not have a full angular coverage, and but in the limit that you would have an infinite accurate time resolution, it's obvious that you would not need the full angular coverage, because each event would be a point. There would be no image reconstruction needed. But this is not so good, but certainly good enough to make the image reconstruction for something that's not a fully surrounding the patients easier. So another thing is the energy resolution. From the width of the photo peak, you can determine the energy resolution. That is also very useful because that helps rejecting gamma rays that have scattered. So you have a 511 gamma ray. Now the probability that the gamma ray scatters somewhere in the patient is not negligible. Only when it scatters, it loses energy, and then when it arrives at the detector, the energy is less. So this, by being able to select only events with the right energy, you strongly reject those scattered gammas, because the scattered gammas again would give you a wrong line, because you would know there was a scatter and you would think the event was on a line, which is not correct. So the next thing then that to look at is at image reconstruction. So you of course have to reconstruct images. Now, we have in order to reconstruct images, you have to do something that is normalization. That is really essential to get good images, and that basically consists of irradiating the whole detector with a source and then basically it determines the detection efficiency for the gamma rays of each pixel, and that is needed to be able to get a proper image reconstruction. So you have a setup, as you see there on the right, so the two detectors, and then you probably see this line, vertical line there, which is a germanium 68 source, which is a line source that is a positron emitter, and we, for normalization, we have the source travels linearly between the two detectors from one end to the other end, and in this way you irradiate all possible detector combinations which you can use for normalization, and you can also reconstruct that image as proof that your image reconstruction is working. So let's try and see that. So this is the case that I've just described. Now maybe stop it and explain what's happening. So let's first look at the left side. So basically there you see three images. One image is in this corner image is the view of the detector you have seen, but seen from the top. So the line source just a point. So you should see a line that travels. The image here to the right is looking at the same line source, but from the direction the line is traveling to or traveling away from. And you see there basically a line that is not moving. Now, the bottom image is now the same image, three-dimensional image, patterns of three-dimensional, but now looking from the direction perpendicular to where it travels. And there you see a line traveling. So now let's go again, and you should really see that. So you see the thing that I just explained, and this illustrates that the image reconstruction is basically working. Okay, so let's. So basically, the conclusion is. First of all, there are several good reasons to think that PET would be a better way to monitor the proton range and proton therapy. And in this project, we have built a realistic prototype PET that could be used for real patient studies, even if we have not done that, and for the time being, it's not the plan, but the detector could certainly do that at some later stage. And the detectors are fully tested and proven to work. We already did some first beam test, but for a number of reasons, the project took a little bit longer. Well, there was the COVID, but not only COVID. Let's not blame everything on COVID. Also at MD Anderson, there were, for a whole period of time, we had no access to the beam, which also hasn't helped. So we certainly need to do a number of beam tests, but we continue the project, and we will certainly finish more beam tests and have more conclusions on what is possible, and to prove and convince other people that indeed this is a better way to do the verification of the proton range than on cameras. So thank you for your attention.
Thank you, Professor Stefan, for this very nice overview of this profitable work. And we will move now to Dr. Celia Fernandes, who will talk us about proton boron capture therapy. Thank you.
So, may I share my screen?
Yes.
Yeah, but I need to put it. I'm not able to share this. Okay.
We are seeing it, but not in presentation mode. Yet. Yeah, now it is. Okay. Yes, perfectly.
Okay, so I will present the our project, our bilateral project with the MD Anderson Cancer Center, dealing with the theranostic strategy for proton boron capture therapy of pancreatic cancer. So it was a bilateral project that has already finished, but the work is still going on. It's I don't know why no, okay, it's not so. As the other colleagues, it's between our group here in Lisbon from Instituto Superior Técnico in Lisbon, and I am working in the research unit of C2TN, Center of Nuclear Sciences and Technologies, and with the MD Anderson Cancer in Houston, so it's very far away, and fortunately we have this program to help us to move and to collaborate with in between the two centers, because it's really very important, because we don't have here the proton therapy to use, so the proton beams for clinical use is there, and so it would be impossible to do this without this collaboration. So we are here in Lisbon, very, very nice view for all of us, but then we move to our project, and the main goal of our project was to prove that proton boron capture therapy can lead to an increased biological response of ductal pancreatic cancer cells that have accumulated boronated compounds encapsulated in micelles in a dose-dependent way, and that was proportional to the cellular concentration of boron 11. That was our main goal. Moreover, we want to have also the possibility of having theranostic strategy, theranostic nature, that in a way that we could encapsulate also a radioactive compound inside the micelles and try to do a MAGE-guided drug delivery of our complexes in the micelles to see if they were able or not to reach to go to the pancreatic tumors, because it's very important that the boron goes there, and so it's important that the micelles are a very good drug delivery method to go directly to the tumor, and you can see it by nuclear imaging techniques such as SPECT or PET. For instance, if we integrate in the micelles a SPECT or a PET radionuclide. So, as all of the other colleagues have already speak about the proton therapy, that is really a very attractive radiotherapeutic strategy to treat different types of tumors. I will not spend too much time on this, and I go on. And I want to speak about the rationale that is behind the PBCT. This is one alternative to enhance the radiobiological effectiveness in proton therapy that is based on the radiation of boron 11 with protons that will produce, as you can see here, free alpha particles that have high LET, and they have higher LET and higher radiobiological effectiveness than protons. And if the tumors to be irradiated have boron compounds inside, they could enhance the cell death when compared with the same type of irradiation only with protons, at least without the exposure, without having there the boron. At least this is our idea, and this is what we wanted to test. So PBCT is a very similar strategy as the BNCT, already known for a very long time. However, it has some advantages in my opinion, since it relies on the nuclear reaction with boron 11. that is much more abundant than the boron 10 that is used in BNCT. So another thing is that the cross-section of this reaction is significantly high for incident protons of low energy around the Bragg peak region. So it's expected that the generated alpha particles in healthy tissues surrounding the tumor should be rather low, and then even if they accumulate a considerable amount of boron 11, it would not be so bad for the healthy tissues. In opposition to what happens with the BNCT, the reaction is, as you all know, with the boron 10 nuclei, and this leads to the formation of ionizing alpha particles in also in the target tissues. What is the challenge? It's really very difficult to do this work, and the first experimental validation was done by our colleague Siron, using prostate cancer cells and also non-tumorigenic breast epithelial cells, and using this sodium borocaptate PSH, and he has seen that there is increased radiobiological effect after irradiation with protons, 62 MeVs or 250 MeVs, based on the size that he have done. However, it's in the beginning, and it's really important to know it better and to study it better, and to study the relevance of PBCT to improve the proton therapy efficacy. Moreover, there are a recent paper that contradicts somehow the results of our colleague Siron. So it's important to continue working on it. The innovation of our project relatively to what has been done by Siron is that we want to deliver the boronated micelles loaded with the boron compounds to radio-resistant pancreatic cancer cells or other type of tumors. We have started with this, but it doesn't mean that it cannot be applied to other type of tumors. And the evaluation of the radiobiological effectiveness upon the irradiation with the clinical proton beam. So we expect to demonstrate that the PBCT will lead to a significant dose enhancement factor proportional to the amount of boron atoms that will be taken up by the tumoral cells. The innovation is really that we have intended to use these polymeric micelles using boronated rhenium and the isostructural technetium-99 complexes, and the boronated rhenium complex would be used for therapy, and the 99 complexes could be used to detect the uptake by the tumor cells. So it's therapy and it's imaging dealing with the theranostic strategy of PBCT. So based on this, we have decided to join our teams, and we have contacted Professor Shun Lee that has experience to prepare branched micelles that were able to encapsulate cytotoxic drugs to deliver to pancreatic ductal adenocarcinomas, and with very good results. So we thought these micelles could encapsulate also lipophilic boronated compounds, and to deliver this type of compounds to pancreatic tumors. In the other side, we have experience to prepare the boronated rhenium 1 and 99 MTC tricarbonyl complexes, and we know them very well because we have prepared them several times several years ago, and they are small size, they are neutral, lipophilic, they are very, very stable. And so they have all the physical-chemical properties to be able to be encapsulated in this type of micelles. Moreover, we also have experience in some type of micelles. Myself, I have many works with the drug delivery of micelles, so we thought it would be a very nice team. And of course, in the MD Anderson, we have the Proton beam, we have the instrument to do the tests then. So we decided to, and we started to select this type of complexes that we already have prepared before and that we know very well how to prepare them. So we have started with them. Each complex have only one boron atom per molecule, and we decided that we will start with this type of complexes. We have also labeled them with 99 MTC with very good radiolabeling yields, and they could be used to non-invasively see if they are able to accumulate in the tumors or not. So that was our strategy. So we have started with the synthesis of the complexes. It has been done by my colleague Elisa Palma, a young scientist, researcher working with us. She have prepared the complexes in very good yields, and she have also characterized them by infrared and by NMR, and they were really in a very pure state. It's important to have this. And we have also analyzed them by HPLC in order to have the retention time correctly and to see if they were or not really in a very good purity or not, and also to characterize the analogous 99 MTC complexes that we intend to produce and synthesize in the future to also encapsulate in the micelles. So after the complexes were prepared, we have sent them to Houston, to Professor Shun Lee, in order they can encapsulate them in the micelles. For this, Zhuzhang Gudong have prepared the polymers. They also have experience on it. He had already prepared this type of polymers before, so he have prepared the polymers in order to encapsulate our complexes. And that's what he has done. He had started with this rhenium complex, rhenium B2 that we called it, but the rhenium B3, if we go further, this one, we weren't able to encapsulate him in the micelles. The complex was very, very insoluble in all the solvents he could use to prepare the micelles. So we give up and we continued only with this type of rhenium complex. So he was able to dissolve the complex and the polymer in micelles, and then he have done the self-assembly in water, and after evaporation of the organic, he had the micelles with a very good entropic efficiency of around 82% also, with very good loading content, and he had analyzed them by DLS measurements, and he had a very nice polydispersivity index, indicating that the micelles are homogeneous and with 74 nanometers of hydrodynamic diameter, which also was good. Since we were not able to encapsulate the rhenium B3 complex, we decided to move on and encapsulate another type of compound also in the micelles, to prepare another type of micelles, where we have used a carborane that has 10 boron atoms per molecule. So it would be better if it's working, because we will have more boron inside the tumor, because in this case, we only have one boron atom per molecule, and here we have 10. So we have decided to go on and to prepare also this type of micelles. And also the micelles were prepared. Sorry, I didn't have here the efficiency and the loading content, but it's similar to the one with the Renew B2. And also, he have characterized the micelles, this type of micelles, and also they were homogeneous and slightly smaller than the other ones, but all of them good to continue with the studies. So then we had started with the cellular uptake studies in order to see if the micelles were able to be incorporated and accumulated in the cells that pancreatic expressed in pancreatic tumors. We have used the MAIAPAC cells, and we have incubated not the compound itself, but the micelles loaded with the complexes at 37 degrees for 6 hours, the micelles with the rhenium complex and the micelles with the curpurine. And for comparison, we have used, and that's the usual standard that is used in the literature, the boron phenylalanine, not encapsulated in the micelles, but in the molecular form. So then we have measured the uptake of boron, and in the case of the rhenium complex, also the amount of rhenium in the cells using ICP-MS. And we have seen is that, as you can see here, we have a huge amount of rhenium. So the rhenium complex is there, and also we have here boron. Of course, since we have the rhenium, this is in nanograms per million cells. The rhenium is much more heavy than the boron, so that's why we have. It looks that we have much more amount of rhenium than boron, but it depends on the ratio on the molecular weight, the atomic of the rhenium and the boron, because this is boron 10 point something, and the rhenium is much higher. And for the B cells with the curpurine, we have also done the same type of incubation, and we have determined only the boron, because in this case we don't have the rhenium. And of course, as you can see, the amount of boron is much higher, since we have 10 boron atoms per molecule. We have also done the cellular uptake of this type of micelles in the MAIAPAC cells at 40 ppm of boron concentration. That is the concentration that we will use in the irradiation experiment. So, as we can see, the compounds uptake by the we have a very good cellular uptake in this type of micelle of the cell. So we have decided to go on, and we have decided to set up the radiation and do the studies. So for this, I was more lucky than Joana Diaz, that we were able to go to the MD Anderson Cancer Center, me and my colleague Filipa, and to do the radiations with Professor Narayan. And he, of course, was the person who was there for us to do all the setup of the radiations and the studies with the cells. But there was a problem, of course, that we only could do irradiations on Saturday, because all the other days the the proton irradiation was used for clinical studies, and so was not free for us. But it was free days that we can, 3 different irradiations that we could do by this time. So it was last year from 4 to 22 of May, and it was a very good short-term scientific vision there, because it's completely different from what we imagined that it could be. So we have set up the experiments, and here we have some the things that we have done. So we have done 5 arrays at the entrance and at distal end, so low-let and high-let, for the same type of cells, and we have used the boron phenylalanine as reference to the cell media control with 40 and 80 ppm, and the micelles with the carborane and the micelles with rhenium B2, both of them at 40 ppm of boron 11. So, and then we have done the irradiation, and we have done the cell viability exposed to our boron compounds, to the micelles. And what we have seen is that, in fact, our compound, the rhenium B2, strongly compromised the cell viability even without the proton irradiation. So only that 10% of viable cells relatively to the control were in there. So they were very, very cytotoxic in this concentration. And as you can see here, even without irradiation, we don't have cells in the clonogenic assay. So we give up from the rhenium complexes, and we decided to go on only with the micelles loaded with the carborane. And so we have done this part of the work that I was showing here was done during our stay there, but then we come to Portugal and they continue to do the irradiations and the studies there. And they have studied the viability in assays in different cell types, and they have seen all of them have some cytotoxicity, radiotoxicity, and then they have done some survival clonogenic assays. And here are some preliminary results. And as you can see here, with no radiation, the survival fraction is really not affected, but with 5 grays at entrance, they are really, the survival decreases, and in the distal end increased even more, decreased even more. So at high-let, the radiobiological effect is more efficient. Here is a comparison between the control, the BPA, the control, and the micelles with the carborane. And here we have done also the clonogenic assay with different doses, and we see that the survival is decreasing with related with the dose. We increase the dose, and in fact the survival fraction will decrease. And so after this, we went to do some DNA matches by gamma H2AX studies, and we have seen that we have lots of foci of gamma H2AX that are formed. But here we can see it in a better way because we have quantified. And as you see, with no radiation, the intensity is completely different when we have the 2 grays or the 5 grays. We have done only at distal and it's higher lead, so that's why it was better. So we decided to do it only in the distal ends. And as you can see, we have number, large number of foci in the gamma H2AX, indicating that we have really DNA damage. So this is preliminary results. The studies are going on, and now we also want to do some biodistribution here. So in conclusion, we have succeeded in the encapsulation of the rhenium complex and also in the carburin in the polymeric micelles, aiming at their use as radiosensitizer in PBCT of pancreatic cancers. The micelles loaded with the carburin was efficiently taken up by the Miapaca cells, as we would like. The designed boronated micelles seem to enhance the radiobiologic effects upon irradiation of the pancreatic cancer cells with a clinical proton beam, in particular for high-lead protons. And to pursue the proposed theranostic strategy, we will radiolabel the boronated micelles with a nuclear imaging probe. In this case, we have decided to use indium 111 oxide that I already have many experience to encapsulate in my own micelles, so I think it will not be difficult, and we aim to perform microspect and biodistribution studies in appropriate animal models in order to see if the boron really goes to the micelles really goes to the tumor cells in a very selective way. So work is in progress, and we are keeping on working together, even if the project has already finished, but it's not easy to do all the work because the radiations are only on Saturdays, and we are far away from from Houston, from the MD Anderson Cancer Center. So, but anyway, here we are, and we are delighted with this collaboration, and we want to keep on going on to see if we can shed some light in this new strategy. And that's all.
Thank you so much, Dr. Celia. It's very nice to clearly see that from all the 3 projects, these collaborations were very profitable. All the projects are ongoing with further work, so it's very nice to see the outcomes beyond the scientific outcomes of these collaborations. So for now, we don't have any questions. I have just one quick question to Dr. Celia regarding the rationale of the application of these compounds. So far as I know, the pancreatic cancer is characterized by an inexistence of good biomarkers that make us give us a good target for any kind of compound to be delivered there. So my question is, what is the route of administration of these compounds that you think that could be feasible? For instance, an intravenous administration will make the compounds to reach the tumor, or will you need to make an intratumoral administration, or did you think about this?
Yes, we had already thought about this, and with also with Dr. Shunli, who is working with this type of mice cells, and that's why we also we are planning the biodistribution studies, because we are trying to take apart from the EPR effect of the mice cells and try to see if the mice cells are able to deliver the compounds to the tumor cell, to the tumors by the EPR effect. So besides this, so it should be end of nodes in the injections, the administration. Moreover, we are thinking about how to functionalize the mice cells in order to target the pancreatic tumors. This is a challenge also, that's one more, but we are already working on it and thinking about it in order to deliver it in a specific way, and not only by the EPR effect, but also in a specific way directly to this type of tumors, because it's really a very, very terrible tumor, because it's usually it's very, very difficult to detect, and when it is detected, sometimes it's really very, very late.
Yeah,
that's it. And we are expecting that when we inject with the radioactive, we can see the image and we can treat with what we can see, and that's more or less on this.
Yeah, it's a great advantage of the technique. Okay, thank you so much for the three of you, Professor Joana Dias, Professor Stefan, Dr. Celia. Thank you for your time and for presenting us these very nice, excellent works on the scope of the UT Austin Portugal program. So for now, I will end the program. We will be back tomorrow for our last session, a theoretical session of this course that will be dedicated to radiobiology. Will be a new topic that will be addressed in this year edition. So we will wait to see you, all of you, here tomorrow. See you, and thank you all.
May I ask something? Can we also join this?
Yes,
yes,
you will receive a link for that.
Okay.
I will
manage this.
Okay,
thank you. It will be very nice, because we are also working in many things in radiobiology, in another type of projects. So I would like to have the program and to see if I can at least see a part of it.
It will be a pleasure to have you here also.
Okay, thank you very much. Bye.
Thank
See you
so
tomorrow.
much.
Bye.
Thank you.
Great, thanks everybody.
Thank you, Professor.